Well, I don't know if my opinion is correct, but I would think that the first thing that I would like to do is, being that he has access to guns, to make sure that those guns are secured. Um, and then, of course, talk to his friends and try to make what they call the collective mindfulness, to try to see if they can help out with that.
Okay, so we're gonna go ahead and jump in. Y'all are ready for us. Me and Kayla were just kind of talking as we were going through the case study. Right off the bat, the first thing that we typically do is look at what their current risk factors are. And then once we've kind of established what we're working with, then we go into protective factors. So obviously, the biggest thing that stands out is he is having suicidal thoughts. It looks like there's a plan established. However, if we were meeting with this individual, we would want to know a little bit more. So we would want to know about intent. Does he have intent on carrying out this plan? Does he have access to ammo? There's a gun in the home, but is it in a gun safe? Is it readily available to use? So those are some of the things that we would want to know right at the get-go. He does seem to have some protective factors. So, that's helpful. It would certainly come into play when we're discussing what the plan ultimately is for him. One of the things that we took note of is that protective factors, he doesn't want to hurt his family, by completing suicide, because there is that prior risk or that prior history of other family members completing suicide. However, the family doesn't seem to be as supportive as we would like to see if we're going to utilize that as a protective factor when we're conceptualizing the safety plan. Kayla, is there anything else that jumped out to you?
Can we scroll down to the questions again? That'll kind of help me jog my memory. Yeah, so one thing we were also talking about is in terms of establishing safety, and I think it was mentioned earlier as well. So not only just identifying whether or not there's a gun, but the location and whether or not he's willing to contract a safety by removing the gun or allowing somebody else to assist in accountability for that. And then that would give us a better idea as to whether or not we would be moving forward with a safety plan or hospitalization, and as well as maybe what kind of additional assessments we would want to do in regards to those risk factors as well. So I'm right there, I'm kind of covering questions 1 through 3. And for right now, that's probably a lot of information. So I don't know if anybody has any other thoughts on that or questions about that.
Yeah, so for any of our TexCHIPers, if you have additional questions that you want to ask or things that you want to add, feel free to drop those in the chat. So for the first question, what other assessments might you use? Lori mentioned the safety assessment, which is a 5-step evaluation. That's a great option.
One thing that we have at our organization, we have a full crisis assessment that we use. It does include the CSSRS questions, but then it goes a little bit more in depth into the mental status exam and things like that. So that obviously for our facility and what we do here with MHID, that would certainly be another assessment that we would use. And then getting to question 3, I was going to jump into the rest of the questions unless y'all are still discussing the first couple.
So I wanted to kind of check in with Julie. I know you're driving, so of course we don't want you looking at the screen, but
yeah, no, I just got done, and I actually used to work for Kayla, and she's a great supervisor, by the way.
My cheerleader.
So if y'all want employment, go over there to MHID. Um, so, but I don't work there anymore, y'all. So I'm not trying to I don't get recruiting efforts or anything. So I would say Jackie was talking about the crisis assessment. The crisis assessments are very, very thorough, and they have a lot of information that we could get from the client, whether they're experiencing whatever, if they're it doesn't just talk about the actual crisis. It talks about support systems, it talks about medications, it talks about previous hospitalization. So it has a really good history, that you can get a really good history of the client. There are times where the client might not remember or just might not want to give the information. And so just to make sure that we aren't triggering the client to feel even more stressed out, we don't force them to tell us the information. And so it's just kind of whatever they want to tell us. And that's where you use a lot of your either counselor skills or your mental health skills or whatever, to where you can pull things out. If it comes from one question, if you ask them one question, but then it comes out in another one, then that's when you can put more information and connect the dots more. Just doing it that way. So yeah.
That's great. So Julia, I know that you're trained in as a counselor, and you're provisionally licensed at this point, but so as a caseworker, how does that kind of differ? How might your perspective differ on this client?
Well, as far as whenever a client tells me that they wanted to die by suicide, or they were having ideation, the first thing we would do is we would kind of stop and pause and be okay, so where's this coming from? Figure out if it was a continuous thing, if it's part of their symptoms, if it's their baseline. There are some people where they have baseline suicidal ideations, or if they're having pretty extensive, looking at their information and their quality of life and all the things that that just kind of captures that person. We would normally do a crisis assessment, and then if we felt the client was not safe, and we would ask them if they could go to the hospital. We would escort them to the hospital, take them there, and then or see if they would go on their own, but of course follow up. And then if we would also take them to the emergency room. If they did not want to do it, we would do detention warrants, and we would have to go to the courthouse. We'd have to go to the police station. We would have to get all the signatures, so that way the judges can get it signed, and then try to get the warrant served to the client, and they take the client to the hospital.
Gotcha.
So am I missing anything, y'all? No, that's it, right? Yeah. Yeah.
Julia, could you go into a little bit more about what that process is like, having to get the warrants? Is it, how easy is it to get all that stuff done?
It's really not easy, and it's not to scare anyone. And it all depends on the logistics, that whole term of it depends. So what it is, you normally call the judge that is on duty for the month. Sometimes that judge isn't available, or when COVID was going on, it was terrible trying to track someone down. So first you get the detention warrant, and you fill out all the legible information. They want to know who the client is, who you are to the client, how you are associated with the client. They want to know what your credentials are, and then they want to know what phrases that the client used, and what information that what makes you think that client warrants a detention warrant. And so once that's good, you get your supervisor to take a look at it, make sure it's all good and taken care of, and then you go to the courthouse, and you try to get that signed. There have been times where I've been allowed to go to a judge's house, but that's because they told me hey, this person's on call, they're working at home. So we've been able to do it electronically. And so it's just getting that judge's signature. And then if there is not a judge around, then you would go to the detention facility that's there on near the big Catholic church, the cathedral, so that jail, and then they would fax the detention warrant over to that judge. The judge would get it signed. They would talk to the case manager that is doing the detention warrant. They'll sign it. They'll send it back, and then we would have to find someone that would have to serve. We don't. We try to find out like where the client is. We try to make sure that we can't have tabs of the client. There is also another, once that happens, there's also another case manager that comes out if so, like, let's say that I was the case manager that the client said that he was suicidal to or she was suicidal to, then another case manager would go out to go get the detention warrant. And if not, then the supervisor would. Someone would go and get the detention warrant, so that way that client is not left alone. And then we would call someone to serve the warrant. So we would try to get close to the location of the client, but we won't stalk them. You know, like if they want to leave, like you just kind of, that's kind of like a really huge like judgment call, because we can't like detain them either. And so we just try to use more probing skills, more asking questions, like trying to build more rapport just to get them to stay put. So that way the warrant can be served. The police officer will come, you give the detention warrant, and once you give the detention warrant to the police officer, then that is in their possession. Like sometimes they might try to give it back to you and you just don't take it back because it is in their possession. Am I missing anything?
Oh, that was really thorough.
No. Yeah, okay. I've been taught well. So yeah, and then at that point, after the client has been taken to the hospital, you do your follow-ups, and if they have been hospitalized, depending on the hospital, you can go see the client as their case manager. If not, then you do check-ins to the hospital that they're at. If the client disappears somewhere, then you still continue looking for that client. Like every day you make those attempts to make sure that you can find that client when that client is still like, if that detention warrant hasn't been served, and you know, like the police officer that has it, then you would call them and be like, hey, I found the client, he's right here. And then they can serve the client that way. So yeah, it's a lot of work, but it's worth it to like save that person. So.
Yeah, thank you for all of that detail, Julia. And something I would like to add for our TexCHIPers is that you are under supervision right now. And I think another caveat to be aware of is every site has its own policy when it comes to clients who may be suicidal. And so this is something that we'll probably re-emphasize even in our training later today, that it's really important that you know what your site policy is, because it may be different and you may not be taking all of these steps that Julia has mentioned.
And if you're ever in doubt, always reach out to your site supervisors. You know, even if you're asking the same question 100 different times, that's what they're there for, right? It's to help you, you know, learn the policies and get as comfortable as you can with following these different types of things. And, you know, like Ash said, every policy is going to be different. And so, you know, right now y'all are in practicum and internship. And so, you know, you're probably going to be at the same sites, you know, until you graduate. And then after you graduate and you get a job, that policy is going to be different. And so never be afraid to ask, you know, what it is that you're supposed to be doing in these situations. There, you know, you're going to have some.
And I did want to say, like, y'all did ask me that as a case manager. So I did want to remind the TexCHIPers that it was case management duties, not counselor duties. Like I've had, when I was in practicum and internship, I've had to call the mobile crisis outreach team or CIT or whoever to come out and talk. I was over at Turning Point. And so, you know, it just took a little bit of facilitation from like my supervisor and myself. And, you know, I let the client like, hey, because of what you said, they're just going to ask you a few questions. So that way the client was aware. of what was going on, because I didn't want to lose that trust also with the client. And so it's very transparent. But the role as a counselor and a case manager are fairly significantly different, because as a case manager, you're not acting as a counselor. You can use some of your counseling skills, but at that point, you're still a case manager or rehab teacher. So.
Yeah, thank you for that, Julia. I definitely think it is important to recognize that, you know, depending on where you're at, some of these duties may fall on you, some of they might not. And so that just goes back to, you know, checking with your side about what the policy is going to be. Because, you know, MHID, it's a fairly large, you know, organization. And so if you're at something that is maybe like a little smaller, you know, maybe they don't have case managers on staff. Or, you know, they do, and the case managers are just extra overworked. And so some of that responsibility still might fall on you. And so that's why I'm glad, you know, Julia was able to give y'all that much detail, just so that way, if you end up in a location where you're going to have to do some of that stuff, you're at least a little bit more prepared.
And one thing that I did just want to mention, so right now, I've been helping to supervise the MCOT department for the past few months. Kayla has just recently been hired on to oversee that program. And so that's why it's neat that we can both be here to kind of show or tell about our experiences with that. But I can tell you with this example, you know, if I were in the role of supervising MCOT as the LPC, and I had the case manager coming to me, picking up, you know, with question 3 here, you know, right off the bat, I can tell you when guns are involved, that's where I typically will err on the side of caution, because we know that that's a higher lethality of a plan. And so the questions that I would ask that case manager next would be, again, do they have access to it immediately? Do they have ammo? Is it stored away? Is there somebody who can help ensure that it's been taken out of the home? If that can't be done, then we know we're looking at someone who has a high lethal plan. He is drinking, so any alcohol or drug use is going to increase the lethality level. And then there's all those other risk factors that we've discussed. So I can tell you, he is one that I would probably more likely than not err on, you know, let's seek inpatient hospitalization for this individual. Another thing I'll tell them, tell the clients is that with antidepressants, it's not you take that first pill and you have an instant effect. It takes a couple of weeks, typically, you know, 4 to 6 weeks before they really will start to notice changes. So sometimes I'll ask the case managers, if we get them in front of a doctor today, when they go home tonight, what is going to change? What's going to help keep those suicidal thoughts from returning or keep them from following through with their plan? And so that's certainly something that we take into consideration, because in the hospital setting, they're not only started on medications, but they're monitored around the clock. So if those thoughts haven't resolved in that meeting between the case manager and the client, then, you know, we still need some sort of way to ensure that that client's being monitored. So if we have a good family support, family can certainly do that in, you know, the person's home, and we do a contract for safety, which is part of the safety plan, where, you know, we're talking with them about how to help ensure their safety, making sure that they know the crisis hotline and what to do should things escalate. But if that isn't in place, then more times than not, you know, we're going to look at hospitalization for that individual. And then, you know, going on to question 4, as Julia had already covered, if they're not interested in that, or they're declining services or declining that they can be able to keep themselves safe or take the steps to ensure their safety, then we do look into obtaining a mental health warrant for that person. As far as number 5, specifically for MHID, we utilize the crisis hotline after hours. But we also sometimes will utilize our CIT, crisis intervention team, that Julia had mentioned a little bit about. So these are case managers who are with the police officers, so they respond to calls. So you have an officer there who's able to, write an emergency detention warrant if needed and kind of help facilitate getting that person to where they need to be to remain safe. But you have a case manager there trained in mental health to do the assessment and to also talk with the individual and make sure that it's as smooth of a transition as we can. But the 24-hour crisis hotline is more useful for, let's say, it's 5:05 and you have your phone's ringing and you pick it up and it's a client who's reporting thoughts of suicide or that they're in crisis. You can call that after-hour hotline and transfer that call to them and kind of let the worker on the other line know, this is, I'm work for this agency, this person reached out, they're reporting this. And so you're ensuring that that person's being transferred over to one of those crisis workers who will then do their screening process and get that person care depending on what they're needing at that time. Anything else you want to add?
That was really thorough as well.
Okay.
I was just going to ask real quick, could you provide the crisis hotline number in the chat?
Sure, certainly. And we're going to cover that as well in the training here in just a little bit. But I'll go ahead and put it in the chat that way you guys have it. Did you want me to go ahead and finish up with the rest of the questions?
Yes, please.
Okay. Let's see. So for number 6, if Brandon were an adolescent under the care of his father, at what point would you involve his father and how would you bring him into the situation? So in general, if we are going to work with an adolescent, even if they're in crisis, we want to make every attempt possible to get the parents' consent before we assess the individual. In Texas, there's a bit of a gray area when they're 17, but in general, we make every attempt possible. But in the event that the parent can't be contacted or located, then we are okay at least doing the assessment. But when it comes to the recommendation, getting them into the hospital, things like that, we still need to have a parent involved. And so with Brandon's parent, we would just explain, first identify who we are, the agency that we're with, and what our intentions are, that we're going to be assessing his child due to reports of, suicide. And typically, we let the child know as well, hey, I'm going to go talk to your dad and just let him know what's going on. We need to have his permission before we can, move forward with this, and do our best to let the child know that we're still here for them, and we want them to know that they're heard, but we also do have a duty to let the parent know what's unfolding because they are still under the age of 18. And so as far as number 7, what preventative steps might you take with Brandon? This is kind of a broad question, but I'm guessing it's asking just as far as doing the assessment and then whatever outcome that may be. If we decided hospitalization, I think the best thing to do is explain to Brandon what hospitalization might look like. What can he expect from that? A lot of times people typically have this idea in mind of what a psychiatric hospitalization is going to be. You're going to be thrown in a padded cell. In reality, that's not the situation. We both worked for psychiatric hospitalizations. And so I always like to give them a disclaimer or kind of paint a picture for them of what will take place. It's not this scary place that people often have in their heads. It's actually a place where you can, be able to vent and talk about what's going on with professionals and get that professional feedback. So a lot of times it just takes basic education to kind of help the person understand what will happen. And once you've given them those expectations, generally they're a little bit more at ease and willing to explore that other option. Obviously, if we go the route of a safety plan, we would complete that safety plan with them. We would discuss how to keep themselves safe within their environment. So again, that could be having a family member remove the gun from their home. It could be putting that person on like a pill box if their plan of method was to overdose. So, you have 5 days worth of medication, your family member is going to lock up the rest of the bottle. That way you still have the ability to administer the meds yourself, but that plan of overdosing has now been secured. So we will look at those options when we're closing out the safety plan. And then as Julia had said, making sure to do a follow-up the next day, checking up the client, seeing how they're doing.
So one question that kind of comes up for me is, what about the clients that maybe aren't as cooperative, that are, a little bit more difficult? I get, there's limitations to what we can do as counselors, but what advice do you have for the students if they face someone who's a little bit more challenging?
Go ahead. Yeah, so that's a really good question, especially from where we're sitting with MHID. That's really very common. That's a daily occurrence for us to interact with individuals who may not appreciate the system as it functions currently. And I think we'll go into that a little bit more with the training and how to sit with a person and not only assess yourself and your own bias and opinions and approaches, but how to receive the client as well. First and foremost, training and following your center's policy and just knowing that as best you can, because that's going to give clarity and peace of mind with how you proceed with a difficult individual, because your safety is always of the utmost importance. I suppose if somebody is resistant to what we're offering, I try to be very thorough, and in the trainings that we do issue out to our staff, and when I say thorough, I mean transparent with the client. I think it's really important for rapport and for trying to build rapport and maintain rapport, that they understand what it is that we're doing as we're doing it. So if that means that we're doing a crisis assessment, just educating on, let's review. You came in, you said these things, made these statements. This is why I'm asking these questions. Using some of your motivational interviewing skills, your reflecting skills, your validating skills, and discussing with them. I'm hearing that you wanted to talk about these things, and I'm also hearing some resistance. Help me understand maybe where we've had a disconnect. So kind of taking a step back and letting them own where they're at in the process is really important for trying to de-escalate a situation that, maybe a client's uncomfortable with. We're not always successful in that, especially when there's substance use or delusions or psychosis of some kind. So at that point, it comes back down to safety and what our next step is going to be, which, if somebody is combative, I would most likely determine that as a danger to self and others, and I would proceed with a mental health warrant. Depending on how unsafe the situation is, if we needed to call, there's sort of steps that we take. And again, every center is different, or every facility is different. But I would typically, have my team proceed with maybe calling in another case manager and starting there. And sometimes we have to know when we're not the best fit for the case. We could have worked with somebody for years, but maybe today is not the day, and so knowing when to seek help from a team member, and also maybe removing yourself from the situation, which will help calm it down, possibly. If the team member is not the best approach, perhaps your supervisor, and kind of trying to review that way. So just taking the steps necessary to try to maintain the least restrictive means or procedure possible. If we need to call for backup, meaning, a security officer or 911, then we would do that as well, because again, safety for client and self is really important. That was like a really long way of saying just just talk to the person. Just be safe and have a conversation. That's really what we try to do.
And it is kind of tricky with crisis work because you have a very short window of time of building rapport. And so part of, if you do go into crisis work, particularly, focusing on how to build rapport quickly is one of the things that if you can get that down from the get-go, you're going to have a lot of success because when you imagine someone who comes in crisis is a very broad term. And crises can vary from individual to individual. So a lot of times they may, for example, come into our center agitated, raised voice. A lot of times they just need someone to sit there and listen to them and be able to open up in a safe place. And so once you're able to let them know, hey, I'm here to listen, I'm here to help you, you'll typically more times than not see that person calm down a little bit and be able to tell you, this is where I'm at, this is what's going on. And from there, that's where the work can start. We can start problem solving with the individual, help them brainstorm solutions. So yeah.
To piggyback on that a little bit, I really appreciate what Jackie was saying as far as crisis is different for everyone and their reaction to that crisis is different for everyone. And a lot of times what we see, we try to allow individuals to identify what their crisis is and ensure that we're not identifying what their crisis is and taking over their situation. And one thing that we run into a lot is kind of reviewing hierarchy of needs. And so we see a lot of individuals who come in who might be in what they're identifying as a crisis. And it might be that they've not had water today, they've not had a glass of water. And it's something as simple as that, but that's huge. Imagine not being able to have a meal or have a glass of water or put on a jacket or, it's raining outside and your client has been, or individual, the patient has been standing in the rain and their socks are wet and now they have, blisters all over their feet and, skin peeling off from, their shoes and everything. So again, crisis is different. And so that situation could absolutely lead to thoughts of, suicide. And we see that a lot, but breaking it down piece by piece and what we've reflected on is just listening. And that kind of helps to rationalize the situation, calm the situation and go from there.
Awesome. Thank y'all.
Mm-hmm.
So we have about a little under 20 minutes or so left for our panel discussion. So I really want to take this opportunity, and if we go over, not a big deal. But I really want to open this opportunity up for our students to ask any questions that they might have.
I have a question. So it's actually one I was going to ask my supervisor. I haven't asked yet, but in the case that this one has a gun, what if you come across I know we're in Texas, it's very common for people to be very protective of their guns. So what if you come into that kind of situation?
Really good question. And that has happened multiple times. Typically we'll first try to see, is there somebody that we can get on the phone and talk to and confirm that they are going to be willing to at least take that gun, maybe put it in their house or put it in a gun safe, be able to, ensure that the gun is still in the home. You haven't, lost your rights to have it. But at least for the next couple of days while you're working on de-escalating your mental health symptoms, we know that gun is somewhere safe and protected. That's option number one, trying to meet the client where they're at and working with what protective factors they have. Ultimately, if they're reporting that they have a gun in their home, they are refusing to secure safety, they have intent on using it, then we would probably go to obtaining a mental health warrant for that individual. Again, just because of the high lethality of gun being their plan and not wanting to take the steps to ensure their safety, because that alone is a huge risk factor, because that's telling me that that intent is still very much there, to the point that they're not willing to consider safety options. What we know about gun use is one of the reasons why it's so lethal. Obviously, you know, if you do use a gun on your body, it's going to have significant damage most of the time that can lead to death. However, it's a quick access to that. You know, if you look at some of the other methods, you know, there might take some time or planning in place, but if you have a gun ready to go, you know, that's before you've even had a chance to kind of process through your emotions, you could have already attempted. And so that's why with gun use, we really take that serious.
I have something to add, and this is kind of from like the VA's perspective. I'm not speaking for the VA, but so I'm a veteran, and I've had like a lot of like my friends die by suicide. Like in 2016, I had 8 friends die by suicide. And one of the things that they provide in some of like the handgun case, like when you purchase a handgun, or just even to get one in general, but they do have gun locks. And so having like, you know, having the gun lock, like making sure the key is given to a friend, because I think with some gun owners, they don't want to give their guns away because there's like that sense of like security that they have just having a gun in the house. And so like, you know, having like some gun locks or, and then I know someone said something in the chat, but it's like itty bitty for me. I'm using my phone. And then, so I don't know what they said. And then in the chat, but then they also, you can also ask a friend to like take the gun. They also talk about taking the gun apart, you know, because like when you're in that moment, like you have to be very intentional to like putting the gun together. And then, so they say like any extra time that you have from like the crisis moment to like putting things together. So there's different ways, like if a person doesn't want to like get rid of it. And that's what like some of the VA suggestions are. And I know someone, like I said something in the chat. I don't see it.
I'm sorry about that. That was myself, Julia. Matthew.
Yeah.
I was confirming what you had said. That yeah, they're free at the VA for veterans. I used to work at the VA, and we keep hundreds of them behind the counter. So no matter where you go to, whether it's mental health or not mental health, those are readily accessible for any veterans to obtain them.
And then, thank you, Matt. And then even if you're not like a veteran, they do have some like, they have like the VA or the gun locks everywhere. Like you just got to look. I know they even have some at MHID because I put some there before. So it's just, you know, they have them. So it's just, I think if they do have guns, to like have them like I said, break the guns apart, or, you know, give the guns away to like a trusted friend, or just put the lock in it, because like they try to reduce the intentional part of getting to gun access. So yeah.
Yeah, thank you for that, Julia. And I'll say a lot of times people are pretty receptive to that. You know, especially when because that kind of shows that you're working with them. You're not trying to take away their rights or restrict their rights in any way. And so, you know, a lot of times, you know, we get that family member or husband, wife, someone involved who's at least aware of what's going on and can kind of help facilitate and oversee that. But yeah, the suggestions you guys had were excellent. Breaking the gun apart, putting the ammo in another place, because then by the time that you know, they've gotten around to putting all the pieces together, should it even get that far, we would hope that there would be a level of processing going on where that individual would take a second to kind of regroup and think about what's happening. So yeah, good suggestions. There was a question that I wanted to address that was sent earlier about the CAMS training. So the question is, I recently attended a session on CAMS. Do you use this for suicide risk? So CAMS, if you guys aren't familiar, it's the Collaborative Assessment and Management of Suicidality. It is a training that you can take, and it's more so for people who are chronically suicidal. And so it's kind of meeting the person where they're at with that suicidality and helping them work through that. So we do have several of our case managers trained in that. That's going to be case managers, and yes, I believe Julia is one, in the higher levels of care where they're working with people who do have, chronic suicidal thoughts. And so there's been times where we have moved someone up to a higher level of care because we're noticing that this is a repetitive symptom that they're going through. And so we want to ensure that we get them with a case manager who is trained in that CAMS. So Julie, I don't know if you have any more insight you would want to share on that training and kind of what all takes place with that.
So I would say that CAMS training is good. I think it's also like situational. Not everyone will benefit from like the CAMS like intervention. But if you do have a client that would benefit from it, then it could do like great wonders for them. And so, yeah, the CAMS. Can I mention something about the safety plan real quick? Can you hear me?
Yeah, sure. Go ahead.
Yeah, okay. Yeah, okay. So one of the things, so no one really likes doing paperwork. Like paperwork is like it is like my enemy. Like I hate it so much. And I know hate's a strong word. But anyways, the safety plan is not just like another piece of paperwork. It's not like another check in the box. From what I was taught, a lot of people are like comfortable when you do a safety plan. And if a client has done multiple, a lot of times they will use the same information on the safety plan, but the safety plan is obviously not working if they're continuing to go into crisis. And so it's okay to change up the information and to kind of challenge the thoughts of the clients when they're trying to like put the same people or the same numbers, or or they say, oh, I haven't been a hold of this person for 5 years, but go ahead and put them down, and stuff like that. And so just being very mindful of what you're doing and putting on the safety plan, because like I said, people will continue putting the same information, or some will, like if you forget to do it, some counselors or case managers or whatever might try to like pull information from somewhere else, and so just being very cautious of like what you do. And it's okay to take a look at previous treatment plan or safety plans, so that way you can see like what was on there before, what worked, what didn't, and try to like make it more recent than anything else, and just more functional on the treatment plans. And then the other thing with treatment plans is that whenever I would complete one, I would try to give them about 2 or 3. One would go in their file, of course, the original would go in their file. Yeah. And then, or when it depends on what agency you're in. I would try and give them at least a couple of copies. So that way they can keep one in their wallet. They can keep one like in their bathroom. They can keep one next to their bed, just like whatever areas that they frequent. So that way they would have, like, if they do go into crisis, they can be like, okay, I can call these people. I have this information. I'd have them take a picture of it and put it as one of their favorites, just whatever they could do to have that safety plan like readily available to them. But yeah, just making sure it's current, not old info. Yeah.
That was really good info, Julia. And I'm glad that you spoke on that, because I think, a lot of times we hear the word safety plan, and one of the biggest takeaways that I would like for everyone to kind of understand is this safety plan is not a no harm contract. Those are two very different things. And a lot of research says that those no harm contracts are in fact actually not effective. With the safety plan, it's not like you're telling that individual, okay, you're signing that you're not going to hurt yourself, right? When you're in the mindset that you're having suicidal thoughts, we know that we're not processing information as quickly and accurately as we would if we are in a healthy state of mind. So this is kind of a cheat sheet for you to know and reference, okay, these are coping skills I know that will be helpful. These are people I know who will be helpful. These are agencies I know that will be helpful. That way, we're taking the thinking out when you're in that state of mind and you already have it laid out that this is I've already identified for myself things that I can do, people who can help me when I'm in that state of mind.
Can I just say I like the aspect of it's kind of challenging the client to be a little bit more thoughtful in their in their safety plan, in their contacts, because like Julia rightfully brought up, if it was working you wouldn't be here right now. Kind of, I mean, obviously not say that to their face, but that same idea. It's like if that was working, um, how are we still in this place? And kind of changing that whole paradigm that they're operating from, rather than just getting like mired in. Because I know in the healthcare industry, that's where I have most of my experience. In the healthcare industry, it's easy to become burnt out and just go, okay, just let's do the quickest thing because I've got X number of patients still to go. And I imagine the mental health industry is fairly well the same way. So not phoning it in when it can feel otherwise comfortable to do so can make the difference between whether they survive the night or not.
Absolutely.
I think that's I think you touched on a really important topic as far as burnout. So, but just to reflect on that, not to go too far into it, but I don't know, maybe I just lost my point. Yeah, that was fun.
Yeah, I think it certainly does at times take a level of creativity. And a lot of times you'll get people.
Oh, I found my point again.
Oh. Go ahead.
Who's having a good time? I wanted to say, I'm so sorry. I'm not meaning to interrupt you.
No, you're good.
What I was going to say, touching on what Matt had said, is it is important because if you take the time, even though it does feel like you could get burnout, but if you do take the time to process with that individual, hold them accountable, and do the detailed work, you're saving not only that individual, but yourself a lot of time in the future as well. Mm-hmm. So while it might seem harder in the moment, you're really doing yourself a solid for later on down the road. Mm-hmm. And that was it.
Yeah, absolutely. Well, and we'd already touched on working with difficult clients, and this was something that I forgot to mention when we first touched on that, but when it comes to the safety plan, we might have individuals who are just at a place where they're feeling, pretty hopeless. And so they might say, I don't have anyone I can call. I don't have any coping skills. And so as, the mental health provider, it can be very frustrating because you might know, oh, you can do A, B, C, D, but if the client doesn't have that buy-in and they don't see that as something helpful for them, how helpful is that really then? So that's when we have to get really creative and might have to steer the conversation elsewhere for a little bit just to kind of get, their mind away from that and then start talking to them. Yeah, when was the last time you did feel happy? What was going on then? Can you tell me about that time? Especially if you know that they had an attempt in the past or had suicidal thoughts in the past but did not attempt, let's talk about that. What helped you get through that period of time? And so those are kind of the guiding questions that we'll use when we're helping to explore that with them. Let's see. So we don't go into safety planning in this training specifically. So we're sticking more to just the assessment, so assessing for lethality and things of that nature. But I wish I would have added some slides. But I think this is a pretty good topic that we're having this discussion right now because it is helpful. And so these are a lot of the points that I think, if you go into an organization, you're shown this is the safety plan, this is how you do it, now go forth. But sometimes, you need a little bit more guidance than that. What do I do if they say that they don't have anyone that they can call? What do I do if they don't have coping skills? So those are just some of the things that I know, being as a case manager and a counselor, that I've ran into when working with people.
I do have a question for y'all, if I could. Kind of more personal for y'all individuals. I know in practicum class, one of our first major projects we have to do is a lethality assessment in a mock setting. And I could speak for my class. There were still some people who felt like had that uneasy feeling of addressing the topic of suicide. It's kind of like for people that have been doing this for as long as you have, what are some ways that y'all may have overcome that personal discomfort to be able to do the right thing to address the individual?
For me, sorry, Kayla. Sorry.
Go for it.
Okay. For me, I practice like a lot. I ask myself in the mirror. I like just listened. I used different ways to ask, but it was still very like direct and to the point. And I knew not to say, "Oh, you're not thinking about killing yourself, are you?" Like, it's just because that just closes it off, And so I would practice different ways, like just, like I said, in the mirror, or like I would like, and this sounds cheesy, but like I would kind of like ask a friend if like, "Hey, can I ask you these?" or something. And I think it takes a lot of practice to be comfortable asking. And when I say comfortable asking, and yes, I did do air quotes, every time I do ask, and I'm very comfortable talking about suicide, and every time I do ask though, there's still that like little bit of like adrenaline that does pump, and because like the one thing, like, of course you want them to say no, but then like if they do say yes, like, oh gosh, what do I do? Do I have the resources and everything else? And so I think it's just practicing and then knowing like how to reply, and then just also watching YouTube and stuff like that. But and when I say practice, I don't mean just asking it in your head. I mean like saying it out loud and like saying it and trying different ways. And that's how I grew to be comfortable with it. And then, like I said, I had a lot of friends that died by suicide. So for me, I think it was just, I was tired of my friends dying by suicide. And then so like, I would just like straight out, like just ask folks because it's sad, and that's what helped me through it. So, yeah.
I think it'll also help. Just there's a level of increased confidence or comfortability, like when you do join with an agency and knowing like what their assessment tools are. Like for us specifically, I think this is helpful, especially for new hires, whether it be a counselor or a case manager. Our crisis assessment is specifically laid out with sentences that are required to ask exactly as it's stated. And, that takes a little bit of the burden away for people who are learning how to assess for these kinds of things, because you're not having to come up with those kinds of statements on your own. Although it's, pretty clear cut, it's one sentence, a couple of words. But that's part of the learning process is what is your go-to, like Julia was saying, your go-to question going to be? And then practicing it. So, if your agency has sort of a go-to question, I would start familiarizing yourself with that. And then you can become, you can adapt it to language, or not language, but, tone of voice and, your own rhetoric that makes sense in the moment. And I wanted to kind of touch a little bit on what Julia said, as far as like knowing what to say and getting it right. And I'm not calling you out in any way, shape, or form, but the person in front of you is like respectfully, like doesn't know the difference. And so if you don't say it in your mind right, that's okay, because you can always rephrase. And if there's a disconnect, that's an opportunity to say, maybe I wasn't clear. What I'm trying to find out is XYZ, or do you plan to kill yourself? And,
that's what I meant. That's what I meant. I promise.
Yeah, no.
Trying different ways.
Yeah, I love what you said, but it's just, we are hard on ourselves, right? Like, yeah. I think we're all probably here because we do want to, help individuals. And so we hold ourselves to this like mass accountability of getting it right. Mm-hmm. And there's no such thing as getting it right. Yeah. Every person that's going to sit in front of you is different, and your rapport with every individual will be different, and you will learn to adapt to that and adjust to that. And so it's not about getting it necessarily right. It's just about being in that moment, being present for that person, saying the statements that you need to say, and adjusting, having conversation. It's a conversation between two people, you know, and you just adjust as you go along, while being inclusive of your center policies. Yeah, so I just wanted to kind of, you know, be kind to yourself, because, you know, and these things, you know, the tools that we use, the assessments that we use, the language that we're using, right? Like, you know, we've said today, you know, die by suicide, and then it transitions to, are you trying to complete death by suicide? I've known somebody who suicided. You know, the language is always changing. There's all these things that are, you know, that we're having to stay, you know, informed on. It's impossible to get it right, because it's always adapting, and we're adapting with it. The person in front of you considers you the expert, right? So they're not going to be like, you didn't say that to me correctly. That's not where their mind is. Okay, they're going to entrust in your judgment and your statements, and they're going to respond based on what it is you hand to them. And if you need to adjust that for clarity, then you adjust it for clarity, and whatever else you need to ask to get that specific answer. So hopefully that helps.
I definitely thank y'all for sharing that perspective, because I think for many it's getting caught up in that fear of manifesting that which we're trying to prevent, right? So no, definitely thank you for sharing.
And in fact, in the training that we're going to do here in just a little bit, we go into that a little bit more in depth when we talk about the myths of suicidality. And so that's a big one. Is I'm going to give you all the answer ahead of time, but that is a myth. If you ask someone if they're suicidal, you will put the idea in their head. That is a myth. So generally speaking, when you do open up that topic of suicide, in my experience, I often will sometimes see a sense of relief, because it can be a lot for a person to be holding on to those feelings and not really sure who they can say this to or when. So you're taking that pressure off of them by putting it on the table and saying, you're in a safe space. This is what I'm trying to help with. Are you having thoughts of suicide? Are you thinking about killing yourself today? And a lot of times you'll kind of see that change in that person's face and their body language, because now they're not having to think about, how am I going to get this out? How am I going to let someone know what I'm really thinking? We've already opened up that dialogue for them to be able to have that conversation with us. So a lot of good questions.
What other questions do y'all have? Okay. So thank you to all of our wonderful panelists. A lot of helpful information. And so what we're going to do now is we're going to take a little bit of a break. We'll say about 15-ish minutes. And then we will come back and we will start our zero suicide training. Okay. All right. So just, I will just say like 10, 20, y'all come back. Okay.
Thank you, Melanie. Bye, Ashley. Bye, Kayla. Bye, everyone. And Jackie.
Bye, Julia. Good to see you.
I gotta go do volunteer work now. All right. Love y'all. Bye.
Yeah.
All right, everyone. So let's go ahead and get started with our presentation portion. So Jacqueline, I went ahead and passed over presenter privileges to you. So let me know if you're having any issues and I'll get you set up on the backside.
Okay, let me give it a go. I will let you know. Let's see.
Can you flip those though?
Do what?
Can you flip this to this screen?
Oh, yes, let's see.
To move this to that screen, right?
Yes, sorry, guys. User error. Okay, so I think it should be on this one, right?
Close it down and open it back up so it's updated.
Okay. All right. Is this showing on y'all's end?
Yes.
Perfect. Okay. All right. So we're going to go ahead and jump right in. So we're going to be talking about crisis services, assessing for lethality and risk, and then of course the zero suicide framework. So just to start kind of giving you guys a little background on us. So my name is Jacqueline Miner. I supervise the intake department as well as the CBT department here at MHID. I do have some former history here as a case manager. And then before that, I worked at Northwest Psychiatric Hospital up in Calallen. And then prior to that, working at Avail, which is the crisis hotline number that we had shared earlier. So when it comes to crisis work, I've been doing that for many years now. And this is Miss Kayla.
Hey, so I'm Kayla Burrow. I've been with the center for 3 years. I started off here with the assertive community treatment team, which is an intensive outpatient level of care. And then I also was overseeing our forensic assertive community treatment team. I'm actually still clinically supervising both of those departments. But I've recently moved into the position of our mobile crisis outreach team supervisor, actually just 2 weeks ago. So prior to that, I worked for Memorial Hospital for their psychiatric department. So I did crisis assessments and intake assessments for the psychiatric facility, but also for Christus Spawn and their emergency room departments. At the time, it was Memorial, Shoreline, and Spawn South, and then any assessments that needed to occur on the floor as well for possible admissions. I have counseling experience with Gray Matters group. I did that for about a year. I don't know if any of you guys are familiar with Gray Matters, but they specifically they run group counseling for those who are mandated to sex offender treat. I forget it's LSTOP. I forget the acronym, but so I did that for a year. Yeah, so if y'all have any questions about any of that for Jackie or myself, just let us know.
Also, is it showing the large PowerPoint, or are you guys seeing like the template where it's got your preview slide and then other stuff on this side? I can't see on my end, so just want to make sure.
It's okay. We're seeing your presenter notes.
Okay, then let me see if I can switch it. Let's see.
Take your time. It's okay.
Let's try that, and then I'll move you guys over here. Okay, is that better? Is it showing the full screen now?
Yes, just your full screen.
Perfect. Okay. All right, so before we get any further, we just wanted to do a disclaimer because obviously we're going to be talking about the topic of suicide, and we're trying to stay trauma informed. This topic can be triggering for some, and you might not even realize it until you kind of feel those feelings hit. So it is okay if you need to shut your camera off, mute yourself, and take a few moments to yourself to kind of regroup. We did speak with both Ashley and Melanie prior to doing this training to see if they would be able to assist with debriefing should anyone feel like they need that. So if you do feel like you kind of need to talk to someone or kind of process through, please send them a direct message throughout during the presentation, and they'll be sure to follow up with you. Okay. So what is Zero Suicide? So it is a system-wide organizational commitment to safer suicide within both the healthcare setting and behavioral healthcare systems. And so essentially it's a framework where we're trying to take a shift away from the more fragmented type of suicide care and more of a holistic, comprehensive approach. So looking at not just the individual and what they're reporting, but also looking at what policies are in place. What protective factors, risk factors for that individual. So a systems approach to care which focuses on error reduction and safety for consumers and staff. So why zero suicide? So there is some evidence-based research. So the rate of death by suicide is increasing. We do know this. We're going to go into some stats here in just a minute. Zero Suicide's aim is to keep people alive so that they can experience recovery. So, with Zero Suicide, one of the main tenets to it is follow-up care as well. So it's not so much that we're there in the moment helping them through that crisis, but we also want to ensure that when they come out of the hospital or when you follow up with them that next day after doing a safety plan, that we're checking in and seeing, was that intervention helpful? What's helped you through it? What can we build on to keep you moving in this this path of growth and recovery? So Zero Suicide's aim is to keep people alive so that they can experience recovery, and using evidence-based practices specifically addressing suicide and continuous quality improvement system-wide. This can result in a 75% reduction in suicide deaths. So again, we're looking at the preventative measures, the crisis intervention, and then the follow-up piece as well. So this is the latest statistics that were just released. It is of 2019. From what I've noticed, they tend to be about 2 years behind. So this was just released at the end of 2021. And this is through the American Association of Suicidology. So 47,000 deaths total for 2019 that were all suicide related. That is a large number, and a number that has been consistently increasing over time. We can see that the largest age group is 25 to 44, 45 to 64, followed by 25 to 44. So middle adulthood tends to be kind of the range of people that we are seeing completing suicide. That's not to say that the numbers aren't still rapidly increasing for some of those other categories. So elderly individuals, and particularly youths, with the rise of social media and things like that, we have seen an increase in completed suicide in those populations as well. So regarding gender, so in 2019, there were a total of 10,255 females, total of 37,256 for males. So just looking at this, is there anything that pops into your guys' minds about why there might be more completed suicides for males versus females? Typically, it comes down to the attempt or the method that they are utilizing. Statistics show that men more frequently will utilize a firearm, hanging, things like that, that do have more potential for a lethal ending, versus females might utilize things more like overdosing on medications, where you could attempt but still recover, versus if you're utilizing a gun or hanging, the odds that you will survive that are significantly less. So while females historically, based on research, attempt suicide more frequently, males will die by suicide more frequently, and that comes back to the method that they are utilizing.
Just another quick tidbit on this. I was reading yesterday, actually. Yes, so I was actually just going to bring that up, Matt. So one thing that research is showing is that the stigma is still present for males, not only for mental health treatment, but also for medical health care as well. And so females, we're being able to outreach to our female population more often because they're utilizing treatment more often, right? They're going to their primary care physician, they're going to their counselor, they're going to their outpatient treatment. They're following up. So there's more opportunity for intervention for females than there are for males.
Okay, and then as far as ethnic facts, yes, Matt, yeah. So Hispanic and Latinos, so of that, it breaks it down by category. So Hispanic Latino, 4,331, Black African Americans, 3,309, Asian Pacific Islanders, 1,609, and the Native Americans, Alaska Natives, 658. So then, we looked a little bit more into the LGBTQ community. I will be honest, when we were sitting down researching for this presentation, we did have, there wasn't as much research on this population as there were on others. But one of the sites that we found was the Trevor Project. So they do a lot of things for the LGBT community, the trans community. They had a lot of good articles and research statistics. So that's where we got a lot of it. But what we were finding is a lot of the data is around LGBTQ youths. And so that's why some of these examples or some of these statistics are specifically for youths. So according to Trevor Project, the LGBTQ youth are 4 times more likely to make a plan for suicide or attempt suicide. And at least one LGBTQ youth between ages 13 and 24 attempts suicide every 45 seconds in the US. And so according to the CDC guidelines, gay, bisexual, and other non-heterosexual males below the age of 25 are at a greater risk for suicide. This is just kind of my thought, but going back to the discussion of stigma for males in the US, I could imagine that also relates to this as well. And so heterosexual males below the age of 25 are at a greater risk for suicide because they are not only having to fight the stigma, but of males seeking mental health help, but then also battling the stigma that unfortunately is still here regarding the LGBTQ community. So suicide rates by diagnosis. So this is coming from the Zero Suicide framework and the statistics that they have provided. So 2% to 15% of people with a diagnosis of MDD die by suicide. 3% to 20% of those with bipolar disorder, 6% to 15% of those with schizophrenia. So people with alcohol dependence or who use other drugs have 10 to 14 times greater risk of dying by suicide. Again, is there anything that jumps to mind in regards to that last point about suicidality in regards to alcohol drug use? In general, I mentioned previously when it comes to substance use, alcohol use, we know that increases the lethality risk, can't speak today, because of course we're not thinking as clearly, inhibitions are lowered. And so especially if you add that on to someone who is severely depressed or who's having hallucinations, those psychoactive substances can drastically increase those symptoms. And so that's when we might see people attempt more than what they would if they were sober. So anytime we're dealing with someone who is suicidal and actively under the influence or using those drugs or alcohol, we certainly take that into consideration. So again, follow-up is crucial. Risk of suicide or death is highest within 30 days following a discharge from either the ER or an inpatient psychiatric unit. So I think a lot of times people think once they come out of the hospital, oh, they're good, they've stabilized. In reality, that is the time that we need to be the most focused on our patients, making sure that we're following up, ensuring that they're taking their medication, that there's no side effects of those medications, that they have the support in place that they need. Up to 70% of people who leave the ER following a suicide attempt never attend their first outpatient appointment. And then 19% of people who died by suicide had contact with a mental health service in the month prior to their death. So Norina, I did see what you're referencing. I cannot think of her name at the moment, but she was recently crowned, was it Miss America maybe? But she did die by suicide. I think that was last weekend, Sunday maybe. I don't know if that was drug related. I think kind of one of the things about that case is I don't know how open she was, if she was battling depression leading up to that, or if she had disclosed that. But yeah, so I mean, I think there's been in the past couple of years, quite a few celebrity deaths that have happened. And, you know, I will say with that came about, thank you, sir. Her name is Chelsea Christ. Okay. Yeah, so Jimmy did put the article in there if anyone wants to take a look at that. So with some of these celebrity deaths and things that are more high profile in the media, one thing that has come from that is this topic of suicide and depression in general. That doesn't mean that there isn't still ways to go when it comes to that topic and stigmas that might come with that.
Okay, any questions or comments before we move into the Zero Suicide Framework? Nope, okay. Okay, well, then we are going to move into the Zero Suicide Framework. So there's 7 elements total. And so the first one is to lead, and essentially, based on the Zero Suicide Institute, this involves a system-wide culture change committed to reducing suicide. So essentially, we're working together for that reduction. It's all employees. It's not just, us as counselors or us as case managers, but this framework is established for anybody in the presence of another individual. It's all roles, all employees. It includes review and change of center policies when indicated, and includes a focus on consumer safety. So depending where you work, if this is something that were to be implemented, the Zero Suicide Framework, then you would want to know your center's policies and know how to adapt your approach with individuals based on this framework. The second is to train. So you want to train a competent, confident, and caring workforce, which I think is why we're all here today, right? That's our goal, is to learn how to sit in front of others. We want to help employees feel confident that they can assess for suicidality and assist in intervention when needed. So the way that kind of, flows out onto us is we're helping each other, we're assisting each other to understand. It goes back to the panel conversation of how to be present with an individual, but also how to process amongst ourselves for how we're approaching this with others, how we're approaching it as a team, how we're approaching it with our patients. And also provide evidence-based trainings about suicide prevention to all staff on an ongoing basis. The third aspect is to identify. So we're identifying individuals who are at risk for suicide via a comprehensive screening and assessment. A plan is to have more consistent screening and assessment. So again, this is about the facility you're with and how you implement this across your facility, your employees. So to be consistent in your screenings and assessments of suicidality in all service departments. And for all people receiving center services to be screened for suicidality, even those for whom suicide is not a presenting concern. This kind of ties into us being able to ask that question, that difficult question of, are you having thoughts of suicide? Do you want to kill yourself? oftentimes individuals don't know how, like Jackie touched on this earlier. Oftentimes individuals don't know how to bring that up on their own. So we're giving them an opportunity to kind of remove the stigma, the stress, the anxiety, and we're bringing it up for them. And that just ensures that nobody is essentially left behind, right? We're covering everybody at all times. 4 is to engage. So we want to engage all individuals at risk of suicide using a suicide care management plan, establish an outreach protocol for any missed appointments. For example, here at MHID, if we have an individual who misses an appointment, we follow up within 24 hours via face-to-face. If we're unable to do that, we continue by phone. We do outreach to our jails, shelters, hospitals when somebody has a missed appointment. If there's an emergency contact on file and we have consent to speak with that emergency contact. So again, whatever your centers or organization's policy is going to be, that's really important for you to know in regards to engaging, in regards to all of it actually, but and then actively, collaboratively, and routinely engage each consumer in his or her own role in recovery. So holding them accountable to their own safety, right? We can't work harder than the individual in front of us, but we can definitely present all of the information and collaborate and be present and person-centered so that they have the tools to keep themselves safe as well. And then actively engage family members or other identified support persons in the role of consumer recovery, including lethal means reduction. 5 is to treat. So treat suicidal thoughts and behaviors using evidence-based treatments, treating suicidality as a separate condition instead of a symptom of another disorder has been shown to be effective in reducing suicidal thinking and in increasing consumer involvement in treatment. So in other words, oftentimes, and historically speaking, suicidal thoughts, are linked with a diagnosis, and it's a symptom of a diagnosis, which means that we're overlooking the risk factor that is that symptom, right? So if we approach it as its own disorder, then we're going to treat that separately and have a more positive outcome in their safety. And then develop policies for how to observe consumers with suicidal concerns and train all staff on these policies. Second to last is going to be transition. So we're transitioning individuals through care with warm handoffs. And what we mean by that here at MHID, and this is something that you could, implement within your own organizations. When we say warm handoff, that's a face-to-face collaborative engagement, if you will, between treatment teams, inclusive of the person in front of you, right? So, in a private practice, that would look different because you're rarely going to be changing your client from one person to another, at least not without a step down plan or some kind of treatment plan. But even then, you would want to include your client. You're not going to, you're not going to sever treatment with that person without informing them in some way, shape, or form, and better yet, preparing them along the way, having those discussions throughout each session. So here in a large organization, that looks like literally getting together with a client and one staff or typically a case manager with that client going to the new receiving staff and talking together. Hey, let's introduce each other. This is their main concern today, but historically, this is what we've been working on. Remember we talked about this in our earlier session. You're transitioning to, person in front of you, Jackie. You're transitioning to Jackie because you want to work on these things and she's the best fit for these things. So that way it doesn't feel dismissive. It should reduce symptoms, not increase symptoms, or at least reduce, any anxiety about those changes. Which kind of covered the second point there, includes transitions to and from hospitals and other institutional settings, and includes transitions to and from other LMHAs and LIDDAs.
If I could just jump in real quickly, could you explain what LMHAs and LIDDAs are?
So LMHA stands for Local Mental Health Authority. So that is essentially what MHID is. So in the state of Texas, every county has a local mental health authority. For Nueces County, that's going to be us. If you guys have heard of Coastal Plains Community Health Centers, they service like San Patricio County, Aransas, Jim Wells, some of the surrounding more rural counties. So if you see the term LMHA, that's just referencing the local mental health authority for that county. A LIDA is for the intellectual and developmental disability side. So MHID, it's a very long name, Nueces Center for Mental Health and Intellectual Disabilities. So you can think of it as within the umbrella of MHID, we have our mental health side, and then we have our side that focuses on intellectual and developmental disabilities, which we refer to often as IDD. And so the LIDA just means that there's a local authority that covers intellectual developmental disabilities and mental health. Did that answer your question? It's a lot of acronyms.
Yes.
So the final step within the zero suicide framework is to improve. So you want to essentially assess your organization, improve the policies and procedures as you go, review the effectiveness of your training, the effectiveness of the policies and procedures, your overall approach, and work towards closing the gaps in the system where consumer contact is lost and potential suicidality is missed. So, to summarize, it's having communication, right? And being willing to kind of take a step back and look at what it is that you're doing, being willing to approach your bias, your burnout, your desensitization, because all of those things occur and will definitely sneak up on you. And they occur, institutionally and organizationally as well. It's not, it's not just on a personal level. It's, it's much broader than that. And so this is a really good approach to kind of like implementing change, and then especially to see that change kind of overall and across institutions. When we're approaching it similarly, then we'll have a better outcome, because a lot of our individuals, a lot of our patients are served over multiple institutions.
Mm-hmm. And so that is kind of a general overview of the zero suicide framework. So again, it is a broad idea. It's a concept that agencies can come in and utilize and make adjustments to how they are serving this particular population within their agency. And so, for us at MHID, it has changed a lot of the ways that we do certain things. So our follow-up care with individuals who are being placed at the hospital, we ensure that when they're released from the hospital, we are either there at the door greeting them, as they're exiting, or, the day of discharge. We'll send one of our LPCs in and meet with them, ensure that they know, when they're going to be seeing the doctor, answering any questions they may have regarding their care as they're getting ready to leave. COVID right now has changed a lot of that. We're doing it by phone, but we're still ensuring that we are touching base with that person on their date of discharge. If for some reason we're not able to make that contact as they're being discharged, we will do home visits. We want to ensure that we have face-to-face interaction, because we know that post 30 days is typically they're at higher risk of those suicidal thoughts returning. So making sure that follow-up care is in place. We also now do a mini CSSRS assessment with every intake. That's something new that we started back last May. And we're going to get into the CSSRS here in just a moment. But, that's something historically we did not do as a center that we are now doing, because this framework has we're now implementing that, and when we're taking into consideration all these different tenets of the framework. And so it's been really neat to be a part of that at our agency and kind of see where we started and kind of where we're at now in regards to how we approach suicidality, how we treat it in the moment, and then what our follow-up care is. So at this point in the training, we're going to shift gears just a little bit and go a little bit more into what are risk factors for suicidality? What is a lethality assessment? Going into the CSSRS. So before we shift gears, does anyone have any questions specific to the Zero Suicide Framework? If you do have a question, feel free to enter it into the chat. We'll give you guys just a moment.
There is a question in the chat about the diagnosis. I don't know if that was already addressed because my internet cut out for a second.
No, thank
But,
you. I
yeah.
saw it. Thank you for pulling me back. So I know as it is right now, and correct me if I'm wrong, if anyone knows for sure, but I do believe that there's a Z code for suicide. Some of the hospital settings will see them put that on like their discharge diagnosis. My personal opinion, I do not think it will ever become a full diagnosis because it very much is a symptom related to other disorders. In general, if someone is struggling with suicidal thoughts, there is an element of depression there as well. But, we see suicidal thoughts transcend across other diagnoses. So people with severe PTSD, people with schizophrenia, sometimes they may experience what we call commanding hallucinations. So they may hear voices or even see figures that are telling them or encouraging them to hurt or kill themselves. And so they might not be having, intentions of wanting to die by suicide, but they may feel like they need to in order to satisfy this hallucination. And so we do see suicidal thoughts kind of transcend through other diagnoses. But again, I think it is still very much a symptom of a disorder rather than its own diagnosis itself. And just again, disclaimer, that is my own interpretation, my own thoughts on that. Kayla, do you have anything else?
No, I would
add to that?
agree.
Okay.
Yeah, I agree with that.
Good question. Any other questions before we move forward? I'm going to go ahead and jump right in again. Still keep up with the chat. Me and Kayla will be watching it a little bit more closely. So feel free to put in a question there. We'll see it and we'll answer it as we go. So just starting on in general, what is mental illness? So we know that it's a condition that is affecting a person's ability to think, their emotional state, and their behaviors. To the point that it's starting to have what we call clinical impairment. And by that just means that we are starting to see signs that those symptoms are affecting multiple areas of functioning. So that could be their ability to maintain employment, maintain school, carry out household chores. So, doing the dishes, taking out the trash, keeping their common area clean, affecting their hygiene, and then also disrupting any meaningful or satisfying social relationships. So are they still engaging with their family and friends and social activities as they were, or has that now been disrupted? So according to NAMI, 1 in 5 people live with a mental health disorder. 1 in 20 US adults will experience a serious mental illness each year. 1 in 6 US youth aged 16 to 17 will experience a mental health disorder each year. 50% of all lifetime mental illness began by age 14, 75% by age 24. So it is very prevalent. And, again, as we were kind of talking about earlier, there has been a shift in society where I think we're now more focused on mental health than we ever have been. Not to say that there is still stigma very much out there, but I do think people are a little bit more aware of it and opening up about it as historically we ever were. I think some of that too, comes from whether that be celebrities or people in a higher position opening up and speaking about it to help, normalize and get rid of that stigma of mental health. So while we are still seeing a shift towards, the right direction, there is still certainly work to still be done in that area.
Real quick, another thing I wanted to add is kind of going back to like disrupting, daily tasks. I also want to mention that it also you could see like changes in their behavior that could lead to exploitation or like risky behavior, or also like increased interaction with like our jail systems, like forensic behaviors. We are seeing a lot of mental health related crimes right now, or in general. There's definitely an overflow. So I just thought that was kind of like an important little piece to add there regarding mental illness.
Yeah, and in fact, it's gotten to the point where we have received some funding through Nueces County for some of these newer programs that we have at the mental health center at MHID. So we have a jail diversion program, we have our competency restoration programs, and that those are very much in place because we know, through research that there are people who are being arrested or being convicted of crimes where there is a mental health component attached to that. And so, specifically Nueces County and others as well are looking at, do these people really need to be in jail, or do we need to get them access to mental health treatment? Because that is kind of at the forefront of why maybe some of these behaviors are occurring. So that is something that our agency and the county is trying to look at and improve, which again, just, is really encouraging to see that within our community. So we're going to dive a little bit into depression as well as anxiety. And so with depression, some of the signs and symptoms, we've broken it up into 3 different categories. So physical, behavioral, and psychological. So depression, the physical symptoms that may manifest would be fatigue, and tired all the time, changes in their sleeping patterns. So we might see insomnia. They're not able to fall asleep or stay asleep. On the flip side, we can sometimes see hypersomnia, where they're sleeping 10, 14, 16 hours a day, maybe naps throughout the day. Either overeating or undereating, changes in weight, either weight gain or weight loss. Some of the behavioral symptoms that we might notice would be wanting to withdraw from others, lacking motivation to get going for the day, losing interest in their personal appearance, so not engaging in hygiene maybe as much as they once were, neglecting responsibilities. So we talked about hypersomnia. Sometimes what we'll see is people are lacking that motivation to get out of bed even. They're still so tired, so fatigued, that they will start neglecting other different household chores or tasks. And then psychological, of course, feelings of hopelessness is pretty common, commonly seen with depression, sadness, depressed mood, also increased anger or agitation. A lot of times people will come in reporting depression and they'll say, well, I'm not really sad, I'm really angry. Or on the flip side of that, I feel really numb to everything. I have this sense of apathy. So that's also another part of depression. Some of the more lesser known symptoms that people might report. Trouble concentrating. And then of course, on the severe end, thoughts of death, thoughts of suicide. And then with anxiety, so physical, if you've ever dealt with anxiety, when it hits, it's not fun. You'll feel your heart start beating quickly. Your palms might get sweaty. You might have this feeling like you can't take a deep breath. You might feel nauseous, might shake, profuse sweating. Behaviorally, you might want to avoid certain situations or certain places that are going to be a trigger for your anxiety. In severe cases, we'll see that they are avoiding things to the point where it's starting to have a disruption in their functionality. So we'll have clients come to us where maybe they've lost a job because they were calling in too much, because their anxiety was so prevalent that they were avoiding needing to leave the house or going to work. And then psychological, so decreased concentration, this feeling that their thoughts are racing, feeling on edge, and that excessive worrying where you're finding it difficult to control that pervasive worrying that you're having. Any questions on any of this so far? So risk factors for depression and anxiety. So we know that depression, for example, can be inherited, can be genetic component to that, but also it can be a response to psychosocial situations around you. So a death in the family, loss of a loved one, anything traumatic that's happened, sometimes those events can lead to people having a major depressive episode. Medical conditions, recent childbirth, if you've heard of postpartum, peripartum depression, substance use can, change that chemical imbalance in our brain, and so sometimes that can lead to a depressive episode. Let's see, lack of exposure to bright light in winter. So people in Alaska, for example, I'm sure you guys have heard of light therapy, vitamin D therapy. So making sure that they're getting nutrients even to the body. Sometimes just having poor health or not getting the appropriate nutrients that we need can lead to, a depressive episode. And so what is a mental health crisis? So now that we've kind of reviewed some of the more common mental health disorders that we might see, let's talk about what exactly is a mental health crisis. So this is taken straight from the Texas Administrative Code. So in the eyes of the state, this is what they are determining to be somebody in crisis. So a person who presents as an immediate danger to themselves or to others, or an individual's mental or physical health is at risk of serious deterioration, or the individual themselves believes that they present as an immediate danger to themselves or to others, or that this person's mental or physical health is at risk of serious deterioration. So to kind of put that more into layman's terms, when we think of crisis, we will typically break it down into 3 categories, if you will. Immediate danger to themselves would be translated to thoughts of suicide. Immediate danger to somebody else would translate to homicidal ideations. Decompensation is kind of an umbrella term for basically meaning that their ability to function, whether that be their hygiene, their behavior, their cognition, is decreasing to the point that it's putting them at danger of harming themselves or others. This is also where people experiencing severe psychosis would fall under this category. So someone who is not oriented to person, place, time, situation, who are actively responding to internal stimuli, who might be having those command hallucinations we talked about. Those would all be considered in our eyes a type of crisis. And then from there, we would dive in a bit more and kind of figure out to what extent is that person in danger to themselves or putting others at danger. So risk factors for suicide, there are, through research and studies, some common risk factors that they have identified. As far as gender, so we briefly talked on this, males complete suicide more often than females, although women attempt suicide 3 times more often as men. So again, when we think back to the statistics, I believe it was females had 10,000 people in the year 2019 who had completed versus males had 37,000. And we discussed that a lot of that is tied back to the plan, the method utilized. Women more often will use less lethal methods, while men will use more of the high lethal methods. So again, we also touched on age. So adolescents, older adults, those are the ones that we're seeing a significant rise in those categories, as opposed to the middle-aged adults. Mental illness, chronic physical illness, use of alcohol or other substances, lack of social support. So this is an example, but so evidence shows that not having a spouse can be a risk factor for males. And so again, when we're talking about protective factors and risk factors, looking at those social supports is a common part of that. Let's see. So Matt had asked, do we know if that data is specific to cisgendered males? To be honest, I don't know. Kayla, what do you think?
I'm unsure as well.
Yeah. Like I said, there really wasn't a whole lot of research that we were able to find regarding LGBT community that was current.
And a lot of what we did find, this does not answer your question, but a lot of the research that we were finding in regards to suicide was all linked back to violence within that, like sexual violence within that community. And so it was difficult for us to differentiate, especially for this training, just the overall suicide risk factors, protective factors, and statistics. But that didn't exactly answer your question, but just so you have a little bit more idea of what we were running into while doing this research.
Good question though. And then, so the last two that we have listed there are previous attempts and organized plan. So we know someone who has attempted suicide in the past are automatically going to be considered more risk than someone who hasn't. And then organized plan, what that is meaning is that person has not only having those thoughts of suicide or homicide for that matter, but they have gone to the point where they've considered what their method is. They planned it out. So they know the time, place, and they have intent on following through. If we have all of that in line, then we know we're dealing with somebody who is at the highest risk that we can get when it comes to suicidality.
Another risk factor that I wanted to just kind of mention, because it's not, it's not on here and it's not specific, but self-harm, although it's, it can be broad in a lot of different ways, but it is a risk factor, especially depending on what type of self-harm an individual is utilizing. So if you have somebody who is cutting, although their intention might not be to die by suicide, because of that self-harm action, it does put them at risk for accidentally, completing death by suicide. So that's something to consider when you're assessing and screening as well.
Same goes for just risk-taking behavior in general. So if we have someone who's doing a lot of reckless behavior and they're not putting any caution to the consequences of those actions, that might be someone that, we're going to keep that on the forefront of our mind when we're considering their current risk factors. So that's another good one that we should add as well. And so here's some myths and facts about suicide. So suicide happens without warning. Myth, fact. What do you guys think? This one is a myth.
Great job.
Good job. Yes, this one is a myth. So we know now through research that there typically are things that we will see happen before that person does actually attempt. And so getting to know a little bit about those risk factors that we just talked about is going to be able to help us, that we're about to talk about, are going to be important when determining, is this person at risk of suicide? So this next question, if you ask a person about his or her suicidal intentions, you will encourage that person to kill themselves. Correct. This is also a myth. So we talked about this a little bit before, but typically in general, once you open up that conversation and that topic for them, usually that comes with a sense of relief that now I know that this is something that's okay to talk about. That's not across the board. There might be some people who, if they're not ready to kind of talk about that, or they haven't really sat with, the fact that I am having these thoughts of suicide, you might see that come through as, defensiveness. Maybe not wanting to open up and share. But in general, it's not going to put the idea of suicide in their head. If they've already thought about it, then that's a conclusion that they got to on their own. You asking them about that is not going to incite that idea for them. Improvement following a suicidal crisis means that the risk of suicide is over. Myth or fact? Correct. This is also a myth. So we talked about that post follow-up care. Very important. So while they might be seeming like the crisis is over and resolved, they are at the highest risk of reattempting within those first 30 days. So that's when we want to look at what adjustments can we make to ensure that we're on this track of growth and recovery, whether that be social supports, obtaining medication, ensuring that medication is a good fit for them. All those factors are looked at to make sure that that person is being supported as they're transitioning out of the hospital or post-suicide attempt. So here's some warning signs for suicide. So obviously the biggest one, if somebody is telling you that they're suicidal, take that at face value. So if they're telling you and they're reporting that, then every time we act. Talking, writing, posting on social media about death, dying, or suicide. Again, if they are reporting it, talk to them, see what's going on. Acting recklessly or engaging in risky behavior. So as we mentioned, that reckless behavior, increasing alcohol or drug use. So if you're noticing that, your client or even your friend or family member, they're starting to use more frequently than you've ever known them to use, that could be an indicator to at least check in and see what's going on. Feelings of hopelessness, withdrawing from family or friends, demonstrating rage or anger, wanting to seek revenge, having a dramatic change in mood, feelings of worthlessness or lack of purpose. Regarding dramatic change in mood, there is often, when it comes to suicidality and training and literature, one thing that's mentioned is sometimes you can see a dramatic increase or improvement all of a sudden. So someone that to be severely depressed, all of a sudden they are just feeling really good and it seems like their problem's resolved overnight. Still check in with that person. It could be an indication that they have in their mind decided on suicide. So all these problems that they might have had up until that moment have been resolved in their mind because they have already decided on, their escape out of that situation. So not to say that that's all the time what's going on, but it could be, and it's an indicator to at least check in with that person and make sure that they're doing okay. Any questions on risk factors for either mental illness, suicidality, anything that we've covered so far? Okay.
Okay. Does anybody need a break or anything? Are you guys good to keep going? Just making sure, because there's a lot to cover right here.
We're at about the halfway. Well, I would say maybe a little over halfway. But yeah, we're now going to go into how do you actually sit with someone who's suicidal? How do you ask those hard questions? And then going into the CSSRS. So
everybody's
looks
good.
like we're good.
All right. Okay, so would love a stretch break. I kind of would too. So I snuck that in there. Yeah.
Let's do 5 minutes.
Okay,
that'll be good.
5 minutes. Perfect.
Perfect. So let's resume at 11:20. Okay, guys. Okay. All right. See y'all in a few. everybody? I think we're still waiting on just a couple more to come back.
Okay, welcome back. We're gonna go into how to sit with someone who's in crisis. I think personally, I think that this part is really important. It's a lot of common sense information, but I want to say that when you do engage in a crisis, oftentimes we sort of we go through the motions and we kind of like hit autopilot. And so sometimes we're not actually aware of what it was that we were thinking, feeling, even doing until afterwards. So I think if some of this can kind of sink in for you in the beginning and you start implementing it from the beginning in your own way, it'll just make you stronger down the road. So essentially, when you're meeting with your client or prior to meeting with your client, you want to take a self-assessment, right? And that's important to do regardless of crisis or non-crisis situation, you know. Are you feeling nervous? Are you concerned for your safety? Are you unsure of how to approach the topic of suicide? We talked about that earlier a little bit. And are you feeling responsible for the outcome of the assessment and the client's well-being? So to go over these things a little bit, it might be important to kind of dive into, like, if you're feeling nervous, like, why do you think that is? And who is your go-to person? You know, is that your supervisor? I would hope so. But I would also hope that you have a treatment team around you, peers around you that you can kind of staff that with and kind of gauge. Maybe it's the setup of the office, right? So maybe you're nervous about your safety because the office seems, I don't know, maybe you're not closest to the door. So how to approach the topic of suicide. So again, familiarizing yourself with your organization's approach is probably going to be your best bet. If this is, you know, something more along the lines of like a private practice, you know, practicing your statements, your questions, and becoming comfortable with what it is that you might need to ask. Essentially, all of this is normal, and you may even experience things that aren't listed here, and just learning that about yourself as you go. So what can you do about all of this? Again, I think, you know, if you've been studying counseling in any kind of way, this is on repeat, right? We talk about self-care all the time, but essentially like your own coping mechanisms and knowing what those are. Safety plan yourself. So like, how do you calm your nerves? Like our recommendation right here is to take some deep breaths, right? And through your nose, out through your mouth. But maybe that's not the best coping mechanism for you. Maybe it's a really cold cup of water, you know. Maybe it's taking a longer route to the office so you can walk those nerves off before you sit down with that person, you know, like a longer hallway, or I don't know, but you can figure that out for yourself and practice these different things until you find out what works for you. Safety, I think I've tried to kind of like hone in on that today, is really important because that's going to alleviate a lot of nerves for both you and the client, the person in front of you. So you want to stay, especially in our organization, again, everywhere is different. We like to position ourselves closest to the door. So it does help. And if you guys are working somewhere where you have a diagnosis ahead of time, kind of knowing what you're going into. So if you're entering a crisis situation with a person who has serious mental illness, like I highly recommend being by the door when possible, right? You don't know if they've been using substances, you don't know if they're having increased delusions or psychosis. And you might, not that it's going to turn violent, but you might just need to like step out of the situation for a moment to help it calm down or de-escalate, or step out to get somebody else to enter for you, that kind of thing. We over here, we use like group texting, of course, like HIPAA compliant group texting. But that's another way to kind of ensure your safety, making sure that you check in. And if that's not something that's allowed for you guys, or you don't have a company phone, like inter-office, like Teams or Skype, or literally going up and saying, hey, I'm going to be in office XYZ, doing a crisis assessment, so that somebody's cognizant of your whereabouts at all times is really important. Do you need to take someone else with you? We went over that earlier as well. And ensuring that the client does not have access to weapons while they're present with you. And truthfully, anything can be a weapon. So you have to think of things like desk scissors. Are those accessible to a client with serious mental illness and a client who's in crisis, specifically a client who's reporting suicidal ideation? Probably don't want, scissors, stapler, what else is not? I'm trying to think of like what pens, like I've had clients take a pen and like, try to stab themselves with it. So things that you don't think about on the daily, right? Like could become a weapon. So just being mindful of that. Something else is, we like to decorate our offices, but we avoid glass, right? That could easily become like picture frames, could easily become a weapon. Even like glasses, like I've had clients who have removed their glasses and seem to be doing great, and we're in conversation, and then before I knew it, they had like popped out the lens and were like cutting their arm, right? So it's just you don't know what's actually going through a person's mind at any given time. So open communication and just being mindful of your surroundings and the situation, because the situation is ever changing. Of course, know who to call if you need help. Know your resources, the availability of those resources, and the best way that your client is going to receive those resources. So the crisis hotline, we're going to make sure that you guys have that phone number as well. But when I say receive resources, so we make sure that we write this down for clients. We make sure it's on safety plans. We also give out our business cards. The crisis hotline is on that phone number. So there's like different ways that you can kind of give this information over, so that hopefully one of the ways the client feels comfortable to utilize it if and when needed. There's also CCPD, our local law enforcement, and their non-emergent number, which we'll make sure you have. And then of course, MCOT CIT. Know your site's protocol. If you're not directly handling the crisis, be sure to know what information to gather. This is really important, especially if it were to turn into like an involuntary situation. But it also kind of cuts time off of your assessment. So if you're helping with it, get the first and last name, date of birth, address, their current location, phone number, physical description. We try to kind of assess for like clothing. What are they like height, like not only their appearance, but like what they're wearing as well, and connecting that, because you don't know who all is going to end up involved in helping with the crisis situation. A person could leave your office, and then based on your organization's protocols, you might have that additional step to take. So you'll want that information. And then of course, gathering any of this information ahead of time is going to save you time overall and hopefully reduce any agitation that could occur from a crisis.
And one thing I just wanted to mention, so before Kayla took over the MCOT department, she was a supervisor of our assertive community treatment. So that is the highest level of care here at MHID. So a lot of the clients that she works with have severe cases of schizophrenia, bipolar disorder. And so they might come into treatment with this extensive history of hospitalization and things like that. And so I don't want this information to seem scary to anybody who maybe is kind of getting the feel for working with clients. Like I know, for example, I haven't had someone, use a pen to try to hurt themselves before in office with me. But it is still something to be mindful of when you are working with that person. So knowing what their background history is. So when I was working at the counseling and training clinic on campus, I might not be as cognizant or aware of the placement of pens in my office or things like that. Because the people that I'm working with, generally the training clinic don't come in with a severe mental illness like that. That is part of the screening protocol at that time, at least. And if they did, they would have to be stabilized on medication versus Kayla's setting. She's working with people who will be coming in with a severe mental illness and could very well not be in a place where they're stabilized with their symptoms. So really, that initial intake or a face sheet, whatever you have to go off of when you're meeting with your client for the first time, absolutely important to review that. That way you can kind of conceptualize in your mind before you sit down with that person, what is their history? Are there any pertinent risk factors that I can see just from the paperwork before you sit down and meet with them? So that way you can be on guard and be looking for some of those key words or behaviors throughout session with them.
Moving on to continuing, to sit with someone in crisis. How do we demonstrate empathy when working with someone in crisis? So most importantly is you want to utilize your active listening skills, being present, being mindful. So validating their feelings, using minimal encouragers. So nod your head, maybe like 1 to 2 like catchwords. I think as you develop your counselor voice, you'll kind of develop little statements for yourself as well. And those will be your go-tos. And then also provide a summary and reflection for any pertinent information that they're giving to you. The benefit of summarizing is that if you're wrong, the clients will tell you. And there's nothing bad about being wrong. It's an opportunity for clarification and understanding. And if you're right, then you've just, if you're reflecting back to them and they're like, yes, that is what I meant, or yes, you get it. Well, then you've just magnified your rapport building with that person as well. Okay. Utilize an open body language. I'm sure y'all see me like wrapping up and like, it's cold over here. But like not crossing your arms like I've been doing all day. Sorry about that. But just staying really open, like arms by your side or like open on the desk as you're writing, and like let them know, like, I'm going to be taking notes so I can better understand what you're telling me. And so they'll understand like why you're shifting your eyesight away from them, or why you're writing, and maybe like they could have misinterpreted that for you're not even listening to me, or and then hold their story. So oftentimes a person in crisis is just wanting somebody to listen to them. And that's a great opportunity for the crisis to be de-escalated, like just giving them a safe space to talk. And, again, you're validating, you're reflecting, you're summarizing. How do you initiate the topic of suicide or homicide? So of course, today we're specifically talking about suicide. And we talked about this a little bit earlier, but you're explaining the purpose of your assessment and how it's going to benefit them. So this assessment is assuring that they know they're not in trouble. Like this assessment is to ensure that I'm assisting you in committing to your safety, right? So I need to better understand where you're at mentally, emotionally. Advise them that you'll be writing information, right? We just talked about that. You want to make sure that you're accurate. So just letting them know, I'm going to take notes. I want to make sure that I get everything, written down correctly for the future. Keep the assessment conversational where you can. Every organization is different. Like when I worked at the hospital, as an example, the assessments were really pretty minimal, but very like one word kind of questions. And so it was difficult to make it a conversation. And so as a counselor, you have to learn to adapt those little phrases so that it does just have a flow, and that'll come with practice. Like, the first couple of times might seem a little uneasy, and then you'll know your assessment, right? Like you'll learn that assessment tool. Oftentimes you'll learn it to the point where you don't even need it. And so once you've reached that point, then it is just a conversation, and that comes with practice. Yes. So be direct when asking the questions about suicide or homicide. And we've gone over how that was a myth. Like if you ask, then that might deter somebody or give them deter somebody from talking to you, or give them, thoughts of completing death by suicide, but that is not true. So being direct, being clear, and being concise is going to be your friend. So questions to ask. So this is really good because we were talking about this earlier, and this is kind of, where you want to practice, right? And how can you adapt this to your counseling voice? And so again, direct, clear, concise. Are you having thoughts of suicide? Are you thinking about killing yourself? Like, you don't have to manifest this grandiose, inquiry. Just be simple, be human, and just ask.
And one thing I do want to mention with this part is we always advise people to be very clear and direct. It's thoughts of killing self, not thoughts of harming self.
Yes.
There's a difference between are you thinking about hurting yourself? That could very well mean to the person like non-suicidal self-injury. That could mean suicidal thoughts. It leaves the door for misinterpretation. So when we're assessing someone specifically for suicidality, we want to ask them, are you having thoughts of suicide? Are you thinking of killing yourself today? That way there's no doubt in anyone's mind what the topic is that we are getting clarification on.
So assessing for lethality. When you're assessing for lethality, you're wanting to find out if the person has current or recent suicidal ideation. This is also going to be important regarding the organization you're with and like what that organization determines a crisis, depending on that answer. That could play a role in how you proceed. Also, has the person considered a method of how they will attempt suicide? So there's passive suicidal thoughts, and so maybe there's not plan or intent, even means, but they're thinking about it, right? So like an example of that might be maybe they just don't want to wake up in the morning. Like they thought about what it would be like to not wake up in the morning, versus a method. Examples here would be overdose, firearm, hanging. Does the person have a plan of how they're going to complete their method? So you want to gather information, right? This is your opportunity to have them elaborate. So where are they going to attempt? When are they going to attempt? Does the person have the means available to carry out the plan? This is also really important. So does the client have access to whatever said plan is, right? So do they have access to firearms? Do they have access to pills? Do they have access to scissors, knives? Again, not to be like gruesome or to scare anybody, but this is information that you have to collect. It's uncomfortable at times, but you want to collect this because this is going to give you your basis for how to proceed at the end, or the base for how to proceed at the end. And does the person have intent to carry out the plan? So this is where you're kind of weighing out the risk versus protective factors. What are their protective factors? Do they believe that they will act on these thoughts without any kind of intervention from their treatment team, or their natural support system?
And this is when it comes to intent, in my experience, that can be one of the things that is more difficult to get a feel for assessing at the very beginning of learning how to do crisis work. Because a lot of times the client doesn't know what you mean when you ask them, do you have intent to kill yourself? And so my advice would be practice asking this question and practice figuring out ways where you can reword the same question. So a lot of times I'll tell the case manager, go back and ask the client, if they go home today, what will happen? If that person's like, yeah, no, I'll be fine, then we're looking at someone who has, there's probably not intent on carrying that plan through. If they say, if I go home, I'm going to kill myself, I plan on doing that. And that's someone that we would say has intent there. So just wanted to put a disclaimer about that.
Assessing for lethality continued. So what are the precipitating events that have led to these thoughts of suicide? What are their core beliefs? What are their thoughts? Past history of attempts. So again, this is really important because if they've attempted before, they're more likely to attempt again. So gathering information on, if they have attempted, how long ago it was, what was their method of attempt, and how did it get resolved? Another question you might want to gather here was, did they seek any kind of outpatient or inpatient treatment from the attempt, any counseling? Protective factors, people, beliefs, events that help mitigate risk. Mental status exam, very important. You can gather a lot of information silently from a mental status exam, right? So this is going to be like what you observe and what's gathered in conversation. Their mood, affect, appearance, cognition, behaviors. And you can expand further on a mental status exam, but that's the basics. If you can gather that, you have a pretty good idea of where the person is mentally, physically, emotionally. And then safety options. What are they willing to consider, right? So we want them to be an active participant in their safety. At least that's our goal, right? And then we explore other options if they're unwilling to participate, right? So we want to put it back on them and find out like what they're willing to do. Is that family, natural supports, following up with case managers more regularly, increasing their therapy appointments, psychiatric appointments? Do they need to go to a respite care facility, medication, doctor's appointment? So there's a lot of things that could go here.
And so now we're going to jump into the CSS-RS, also known as the Columbia Suicide Severity Rating Scale. So the CSS-RS is a set of questions exploring suicidal thoughts, plan, intent, method, all of the things that we just reviewed in the previous slide. So the Columbia Suicide Rating Scale is essentially a tool that is free to utilize. In fact, if you go to the website that I have listed, cssrscolumbia.edu, it kind of gives a disclaimer, about their assessment and how they encourage people to utilize it and bring it into their organization or their facility. And so for our agency, we have taken the CSS-RS and adapted it into our crisis assessment. And that is what we utilize when we're trying to determine, is this person in crisis? And if so, what are the risk factors? What lethality level are we looking at? And so the first question it starts off with, first and foremost, everything is within the past month. So past 30 days when you're asking these questions. And so the way that you would ask it is what we have in bold and underlined. So the idea with this assessment is we want to ask it exactly how it's written. Everything else around that statement is conversational. Again, we don't want this to feel like an interrogation. We want it to stay conversational. But when it comes to these specific set of questions, we want to be clear and direct, because again, we're needing to assess for lethality. So number one, have you wished you were dead or wish you could go to sleep and not wake up? Have you actually had any thoughts of killing yourself? Have you been thinking about how you might do this? Have you had these thoughts and had some intention of acting on them? Have you started to work out or worked out details of how you will kill yourself? And do you intend to carry out this plan? Have you ever done anything or started to do anything or prepared to do anything to end your life? So that is an example of how you would give those questions or ask those questions. And so kind of getting into what exactly it is trying to ask or assess. Number one, it's trying to make that distinction between thoughts of death versus thoughts of suicide. So in crisis work, there is a difference between one versus the other. Thoughts of death can be like, I just want to go to sleep and never wake up. Well, that is very different from, I want to overdose on pills and end my life. Do you see how they vary in severity there? So if the answer is yes to number one, then we go into, are you having thoughts of killing yourself? So we've kind of already laid the groundwork for these thoughts of death. Now we want to get more specific and figure out what really is at the base of these thoughts. And then we go into suicidal thoughts with method. So this is, again, are you having thoughts and thought of a way that you would attempt? And then we go into suicidal intent. Do you have any intention of acting on them? And then with number 5, we get into intent with specific plan. Again, this is where we get to very high lethality. Have you had thoughts? Have you worked out the details of how you're going to attempt it? And do you intend on carrying this out today or in the near future? And then number 6, obviously, is assessing for any prior history, because like we'd mentioned, if there is a history of previous attempts in the past, we know that that's automatically going to heighten the lethality of the individual that we're working with, since that is a risk factor. Any questions on this set of questions right here, how we would ask them? Perfect. And so then we go into, if they are reporting suicidal thoughts, then we're going to ask them, how often are you having these thoughts and for how long? I will always tell my case managers, someone who's been battling suicidal thoughts for 5 years and hasn't attempted, in my mind, is typically just, off the cuff, typically low lethality than someone who has never been suicidal, and here they are today for the first time having these thoughts, because that's indicating to me that there's been a drastic shift somewhere to some extent in that person's life. So we need to get to the bottom of it. The person who's had suicidal thoughts for 5+ years, they've been managing them one way, shape, or form, may not have been managing them the best, and they're here to improve that, but we can draw from that and draw what have you been doing to maintain? What can we build upon to further your improvement? So, it's important to know, how long have these thoughts been occurring and how frequent? Is it once a day, first thing in the morning? Are they all day long throughout the day? Have you known anyone who's killed themselves? Another risk factor that we haven't discussed yet is people who have a history of people who are close to them dying by suicide, whether that be a family member or a close loved one. And then, have they been treated for that? Have they gone through any type of therapy or counseling? Or have they kind of just stuffed down those feelings and never really addressed it? That could be bubbling up, depending on what else might be going on at that moment. And then, of course, we do assess for other self-harm. So do you do anything to hurt yourself or feel pain without intending to die from it? And then number 10, danger to others. Do you think about hurting or killing another person? And then it gets specific. Again, thoughts of hurting versus thoughts of killing. When it comes to thoughts of homicide, we do make that distinction. So let's see. That's all for this page. And then, so this last part, that the last 2 slides we're going to show you regarding the CSSRS for our agency, we do go into a bit of a mental status exam with that person. So first we review symptoms. So if they're reporting depression, you'll see we already have a pre-listed out depressive symptoms that we can check off. So some of this is going to be open to the clinician's observation. Others will be direct report from the client themselves. So it goes into anxiety, psychosis. And remember, with psychosis, it could be manic symptoms, pressured speech, flight of ideas, paranoia, thinking others are out to get them, hallucinations. And again, hallucinations can be auditory, visual, tactile, reported problems in functioning, behaviors noticed by the client themselves, and then changes in sleep, changes in appetite. And so going into the mental status exam, we first address their appearance, motor behavior, affect, their thought process, their memory and judgment, orientation. So if you guys have ever heard, they're oriented ×4. I think sometimes people will say oriented ×3, ×5. It kind of depends on the agency that you're working with. Here, often we'll see ×4, and that stands for person, place, time, and situation. So if the person is not aware of who they are, what today's date is, why they're here, that's kind of an immediate indicator to me that there is something going on with this individual, that, we need to help get them stabilized. So mood, speech, thought content, are they goal oriented? If so, that could be a protective factor. If they're saying, I have no intention on killing myself, I have to be to work tomorrow at 8 a.m., or I'm in school, I have to make a good grade, I can't miss a class. That's a protective factor. So we want to know about those things, because that person is going to be less, in our eyes, less of a risk than the person who does not care if they're going to make it to work the next day, does not care about that class. They don't have any future oriented goals. And then let's see, abstract thinking, and then their estimated intelligence level. And then, so this is an example of documenting. So we're briefly going to touch on documentation, but as I'm sure you guys have know by now, being in this field and being in the master's program, when it comes to documentation, it's one of the most important things, because at the end of the day, when you go home and client goes home, the only thing that we have is what's been documented. And so it's a fine line between wanting to include enough details, but also keeping it, but not being too specific on certain things. So, for example, we are going to want to know about the extent of their suicidal thoughts. We want to know about precipitating events, maybe what led up to this. We don't need to know backstory of a conversation that had 5 years ago that was in some way traumatic. While that's still relevant to the client as a whole and their treatment approach, if that's not applicable to the current crisis and what's currently has caused them to be in a state of mind, then we're not going to spend time focused on that, because we don't want to deter from, our main goal, which is figuring out what's causing this person to be in crisis and what solutions do we need to look at to keep them safe. Does that make sense? So we want to stick to the facts always. So we don't want to put our assumptions in. If we do want to put in an observation, perfectly fine, and it's encouraged, but we want to make sure that we're reporting it and documenting it in a way where it is factual. Client was observed to be dressed in clothes that were visibly soiled, hair was disheveled, unkempt. Those are some of the languages that we'll use when we're describing what the person is appearing. So for this example, we have client reports current SI. This is an abbreviation for suicidal ideation. Disclaimer on abbreviations, so it's going to be specific to your agency. For ours, some of the more general abbreviations are approved, but we do have a set list of ones that we can use. So client reports current SI, suicidal ideation, with a plan to overdose on pills, however denies current intent. Client reported having suicidal thoughts off and on for the past 2 weeks. According to client, he quit taking his medication 3 weeks ago because he did not think he needed them and did not like the side effect of feeling like a, quote, zombie. Client explained he is ongoing conflict in his relationship and his girlfriend broke up with him 2 days ago. He states he cuts to release stress, describing himself as a cutter for the past 2 years. Client last engaged in self-harm 1 month ago. He denies AVH, auditory visual hallucinations, including command. Client does describe wanting to, quote, punch people who provoke him, though consistently denies homicidal ideations. Client reported he is a supportive brother who wants him to get help. So in this summary, we know that we're dealing with someone who's having current suicidal thoughts. They do have a plan, however, they're not intending on acting on that. We do know that the duration has been for about 2 weeks. So they've been somewhat managing these symptoms for at least 2 weeks' time. We know that he stopped medication, which if you know about medication, there's a process to get off of them. We do have to wean off of medication, not stop cold turkey. When we do that, that certainly could be a factor in having thoughts of suicide, increased depression, things of that nature. So we also know that this person had a recent change. So they had a breakup 2 days ago. So that could be considered the precipitating factor. We also know that he does have a history of self-injury. So as Kayla mentioned, when we have self-injury mixed with other risk factors, that is something we need to take into consideration, because that means he's probably got access to sharp items and he's already engaged in inflicting some harm in one way, shape, or form. So if this person were to continue to escalate without intervention, that could potentially place him at very high risk of hurting himself. So we know he's not having any hallucinations. And while he does seem to have some aggravation, wanting to punch people when provoked, he is not having homicidal thoughts. And we know that he does have a protective factor, which would be his supportive brother who's encouraging him to get mental health treatment. Any questions on the summary or documentation in general? So information to consider, just kind of a brief overview. When it comes to lethality, we want to report on or document on the suicidal, homicidal ideations. And then we want to, with that, include what is their method, is there a plan, intent, do they have means / access to that plan. If they're having homicidal thoughts, who is the target? And how long have these thoughts been going on and to what frequency? We want to address psychosis. Are they having hallucinations or delusions? We want to address substance use, self-care, and cognition. So current risk factors. So we want to look at any history of attempts, substance use, impulsivity, easy access to lethal means, and then protective factors. So is there family community supports? Positive relationships with children. We hear that one a lot. I would never do anything, I have to be there for my children. They are my main reason in moving forward. Or, I would never kill myself. That goes against my religious, spiritual beliefs. So when people say those kinds of things, that is considered a protective factor. And then, of course, their coping skills. Again, if they've had a long history of dealing with suicidal ideation, what's helped them manage so far, and what can we build upon? So possible crisis outcomes. So again, just want to do a quick review with the definition of a crisis. So danger to self for others or deterioration of their mental health. So one of those outcomes could be a safety plan, which we talked a lot about in the panel discussion. So listing out for them, what are their coping mechanisms? What are their natural supports? What local resources can we write down on paper so this person has a quick reference guide should those thoughts return? How can they make themselves safe? And again, we went into like putting a gun lock, separating out the different parts of the gun, having a family member watch over that or secure that weapon. Giving them like a 7 or 5 day pill box so they don't have access to a whole bottle. And then, in extreme cases where there is high risk of lethality, inpatient psychiatric hospitalization. So here in Corpus, the 2 hospitals are going to be Bayview Behavioral off of Wooldridge and Oceans Hospital, which is formerly known as Spa Memorial Hospital. So those are the 2 psych facilities here in Corpus. However, they can go to any local ER, because what will happen is they're going to go to the ER. They're going to be evaluated, meaning one of the doctors or a contracted assessor will come in and meet with that client. We'll assess them to see if they are a good fit for psychiatric hospitalization. And then from there, they will facilitate that transfer to that hospital. And then a welfare check, sometimes called a wellness check. You'll hear it called both ways. Basically, what the wellness check is a police officer or a sheriff's department, depending on the area, if you're in city limits or out of city limits, will go to that individual's home, knock on the door, check in with them, make sure everything is okay. So we use this quite a bit at MHID for individuals where maybe they called in stating that they were going to go to the hospital. We call to check in an hour later, ensure that they made it there safely, and they haven't. We try to call client, they're not answering. We'll do a wellness check. So we'll use CCPD non-emergent. So that number that we have listed there, and say, hey, my name is Jackie. I'm calling from New Oasis Center for Mental Health. I had a client come in who reported thoughts of suicide. They were supposed to go to the hospital, confirm with staff that they have not arrived. They are no longer answering their phones. I would like to request a welfare check, and they will dispatch officers out there. A lot of times they won't follow back up. And that is just part of their protocol and confidentiality. So sometimes they'll call and they'll let you know the basics or keep it general. We were able to reach someone, talk to them, situation has been handled. Sometimes they won't give you anything. And it depends on who you get on the phone or who you're talking to. Some other possible crisis outcomes. Not all crises end in a safety plan or hospitalization. You know, again, at the beginning, we talked a lot about what does crisis mean to the client themselves. Sometimes it could be they've had wet socks and blisters and it's cold outside and they haven't had a warm meal, and all of that together is creating their crisis that's presenting in a form of a very upset or disgruntled person in the lobby. You know, so figuring out what exactly is going on and then working towards finding some solutions. So that very well could end up at referring that person to a respite center. Pathways is the respite center that we use here at MHID. Providing community resources, teaching them coping skills even. You know, a lot of benefits to breath work. So teaching someone how to deep breathe. Maybe they were battling a panic attack when they came in and you had to sit down with them and kind of guide them through that. They're feeling calmer. Crisis in their eyes has now resolved. You know, so just keep in mind that until you sit down and you talk with them, you know, that's how you're going to be able to determine what the crisis is and how to proceed from there.
So we mentioned the crisis hotline earlier. If you guys want to take that number down, it's going to be a really good resource for both you and the clients. And essentially a hotline is a service that's available 24 hours a day, 7 days a week. They're there to provide information, screening, intervention support, referrals to whomever calls them. They are also trained and competent in crisis, and they are accredited by American Association of Sociology. So there's some protocols that are followed in regards to calls that go through the crisis hotline. And that is that crisis response times would include, if it's an emergent, then it will be flagged as emergent, and you have 1 hour to respond. That's the protocol that we follow. So just kind of know that if you're giving these referrals or the phone number, that this is what the person calling can kind of expect depending on the screening, is essentially why we have this here. So again, emergent is 1 hour, urgent is 8 hours, and follow-up would be within 24 hours. And the crisis hotline is contracted to collaborate with our mobile crisis outreach team. So at MHID, our team would follow up based on however the hotline flags the calls. So 1 hour, 8 hours, 24 hours. And then a little bit more about basic about MHID services. So this will also be beneficial for you to give out to your clients. Mental health services we do provide here for both adults and youth. We have our crisis services, which consist of the mobile crisis outreach team and our crisis intervention team. Over the past year, we've also added a walk-in crisis clinic. We have a crisis respite center, which is sort of a less restrictive means for somebody who's in crisis. It requires a crisis assessment by MHID for them to have admission. And then also the person who's admitted to the crisis respite, it's typically a short-term stay, maybe 1 to 3 days. They have to be a client of MHID as well. And then we have continuity of care. This is a really important branch of MHID because they work with our hospitals, local and across Texas, regarding any admissions and discharges. They also help with emergency detention warrants. So again, depending on your facilities, your organization's protocols, if you ran into an issue where, hey, I think this family member has questions or concerns about XYZ that might result in an emergency detention warrant, you could refer them to us, and continuity of care would step in and educate on that. We also have our intellectual and developmental disability services, and they provide a separate IDD crisis intervention. They have their own crisis team for that.
And for that crisis program, they are caseworkers who are trained in helping people with an intellectual or developmental disability. So they will go out there and, assess the situation and link them with resources as well. I did put in the chat box, this is the number for our main location here at Brownlee Square off of Brownlee Boulevard. So if you're working with a client and you think that you need to get a warrant for them and want to speak with someone in COC, continuity of care, call that number and let them know, hey, I want to speak with someone with continuity of care regarding a warrant. They'll get you linked up with Twyla. She's our main COC worker. If you're, wanting to see about having a client come in, whether it just be for intake to get into services, to start medication, or you think that they might be in crisis, you want to see if there's a walk-in team who can assess and get them referred to doctor, that's an option as well. So, we do have the crisis hotline that's good for, ease of access. You can get someone on the phone right then and there. After hours, obviously. But if you have someone here in the area and you're wanting to get them in front of a person right then and there, you can certainly call and refer over, and you'll be able to speak with one of the workers who can help coordinate that care as well.
Our mobile crisis outreach team, they provide crisis screening assessments and referrals. They link to psychiatric evaluations here at MHID. They provide medication training and support services, safety monitoring, crisis follow-up and relapse prevention, routine case management, and psychosocial rehabilitative services. The crisis intervention team here at MHID it's a staff embedded with the Corpus Christi Police Department and dispatch, along with crisis intervention trained officers in response to 911 calls involving individuals with behavioral issues, including substance abuse and dependence. So essentially what this is meaning is we have a mobile crisis outreach team that is activated through our crisis hotline or any direct calls to our facility. Our crisis intervention team is activated through 911. That's the difference there. But they may respond to similar events. And then for y'all's use, we have some community resources, of course, us, and then the mental health first aid. We also have a loss team here. So when you guys are working with clients, and perhaps one of your clients has a friend or family member who completes death by suicide, that's where the loss team steps in. So essentially we're here to, we would be notified of that. And then our loss team would reach out to those individuals and just ensure that they have resources needed for their own mental health while processing that event. Again, the crisis hotline is listed here. There's also NAMI Synacor, which you may have heard of. It used to be referenced as Charlie's Place, but that's one of our local inpatient substance treatment facility. Bayview Behavioral Health, Oceans Healthcare, Coastal Bend Wellness Foundation, Amistad Community Health Center, 211 or United Way. There's also the Hector P. Garcia Center, which depending on your population that you'll be working with is really beneficial. It's fairly new. I think it's about 3 years old. It's really new. It's really nice. They have primary care, labs, pharmacy. So again, depending on the population, that's a good one as well.
All right, so that is the end of our presentation. Are there any questions, any comments, any thoughts that you guys had as we were talking that you would like to wrap up with?
I did want to kind of jump in and ask, so there's a lot of we have a really wide net of things that we can do to help people. We have a lot of resources that you provided us. So let's say I'm a counselor in training, I'm working at my site, maybe my supervisor's in another session with their own clients, and I have a client sitting in front of me. I do the suicide assessment. We determine that this person's a pretty high risk, and let's say it's not emergencies. I don't call 911, but I call the MCOT number. What is going to happen in that session? Should I call on speakerphone with my client? Should I call outside the room from my client? What would you recommend that I do?
I'll let Jackie touch on this, but for me personally, just from like a counseling angle, a supervisory angle, I try to be as transparent with my clients as possible. I think that the more the client participates, in other words, referencing your call. So the more the client participates and is aware of what's going on, I think the more positive the outcome, or at least that's been my experience. That won't always be the case, but that's my personal preference and my recommendation. If you can include them in their safety, I would include them in their safety, especially for maintaining rapport, definitely. But if you want to touch on like what it would look like to.
Yeah, so essentially, if you're calling MCOT, what will happen is a crisis worker will be coming out to that location to do a crisis assessment, which we kind of gave you snippets of what that looks like. So it's tied to the CSSRS, it's the mental status exam. So they'll be asking them those questions and then helping to facilitate the plan of action at that point, whether that's doing a safety plan with them, or if they staff with their supervisor and determine that that person needs hospitalization or needs to go to our respite center, they would then, whether they transport themselves or help arrange transportation, they would take it from that point forward. They would enroll them in mental health services through us. So they would be fully enrolled through our MCOT team. So they would be given a doctor's appointment with our psychiatrist, and they would continue that crisis case management. So they would have that follow-up care. Typically, people in our MCOT program, does depend on things like insurances and eligibility for our mainstream services, but they're either going to be transitioned to mainstream services, or once that crisis has resolved, they're going to help link them up with a psychiatrist in the community to continue with that medication treatment or get them into therapy, depending on what the client's wanting from that point forward. So really there's one of two ways. You can either call crisis hotline. They're going to do a brief screening by phone with you. They'll want to talk to client as well to confirm info. They'll dispatch the MCOT worker, call them and say, hey, we have somebody at this location. Crisis worker will call you, let them know that they're on their way out there. Then they will come in and do the assessment at that point. So that's option one. Option two would be if you call our facility directly, the client will speak with that crisis caseworker. And then from there, they'll ask, do you want us to come out to you or do you want to come to us to be assessed? So that's what that will look like.
Good question.
Mm-hmm.
Thanks.
We did throw a lot of resources at y'all. So, I hope it's not too overwhelming. Both Kayla and myself are more than happy to answer any questions that might linger, after we conclude today. So I will drop my email and my office number here in the chat. So feel free to save that and certainly reach out if you have any questions.
I did have a question real quick about the LOST program that you referenced earlier. Is that LOST program also like accessible to youth clients at MHID?
Mm-hmm.
Oh,
yeah.
okay.
Yeah. So, and correct me if I'm wrong.
It's the LOST team or?
Yeah, I guess. Can you talk a little bit more about is it a program that's distinct from the other programs at MHID?
So it's essentially a team. It's not providing services to clients. It's just a resource, just a tool. So we have our LPCs within that team. And whenever there is a reported death by suicide within Nueces County, so in other words, we're either notified by the medical examiner or by, sometimes it's a family friend, or so if it's a client or anybody in the community and we are notified, then we contact the family member of the closest relative of that person who completed death by suicide and provide them with resources. So it's not a program where that person would then be enrolled in MHID. It's a phone call. I know that some of the larger counties, they do have a team who's readily available for making face-to-face contact. But Nueces County, knock on wood, we've had a really good, we have a low suicide rate through COVID, I think. And that's when we started establishing it. So I think in the past 2 years, I've had two, and again, we have LPC, so there's more than just myself. Is it like 6 of us?
Anywhere from six to 10, I would
6 to
say,
10,
on a
okay.
rotation.
So I've only ever reached out to 2 individuals.
And you know, some of the sources for last team come from the medical examiner's office. They will call our clinical director and report when there has been a death by suicide. And of course, with family's permission, they will ask them if they want us to reach out. So then from there, we'll contact family. That can happen either by phone or sometimes face-to-face, depending on what the family requests. I know that we have had some of our counselors go out and meet with that person, you know, a week after the fact or 2 weeks after, make sure that those resources were helpful. So it's not going to be like a counseling session. It's more so just there to provide psychoeducation on the grieving process and ensure that that person's informed of the resources that are available to them in the community.
Thank you.
Mm-hmm. All right, well, so I put our info in the chat box. So you got our email and our office numbers. And with that, I think that's gonna do it for us. You guys were great. Thank you for listening and hearing us out this morning. And I hope that this info will help y'all as you go forth in your careers.
Thank you so much, Jacqueline and Kayla. This was very, very helpful information. And it's really going to benefit all of us, not just the students, but all community members. And so we thank you so much for the time and the hard work and effort you put forward in preparing this presentation. And so, you know, thank you again for everything.
Thank you. It was our pleasure.
You're welcome. All right, so we'll go ahead and sign off then. You guys have a good rest of your day.
Thank you. Okay, so it's basically just us TexCHIPers for the rest of today's training. How about we do another brief break? I know that was a lot of information, some pretty heavy topics, right? So do you want to do like maybe 10 minutes? Is that enough? Okay, let's come back at 12:30 then. Okay, we'll just give everyone a few more seconds to kind of get logged in, get your cameras back on and get situated. Okay, so I think now might be a good time just to kind of check in with you all and see how are we feeling about everything that's been presented? What questions do you have that maybe you wanted to ask? Let's just do a little check-in real quick. I can be real patient, y'all. Somebody got to give me something.
So what exactly are you looking about? Check in about the presentation or check in on how we're doing? What give us some places to land?
Sure, both. So how are you guys feeling about suicide assessment, dealing with a crisis at your site? Any strong responses to things that have been presented so far? Yeah, so Matt says the presentation is well timed for practicum. Tell me a little bit more about that, Matt.
Like I said, because in practicum, the lethality assessment is done right at the beginning, and we just finished turning in everything this past week, so it's still kind of fresh on our minds, the entire topic and how to approach it. So to have other people who are versed in dealing with this in a live setting, more information flooding is a good thing like that for something that's so topical for us right now.
Yeah, good. So how are you all feeling about doing a suicide assessment or dealing with a crisis in your setting right now?
Well, just to piggyback about what Matt just said, I wish we would have had that presentation before we did the practicum work. I feel like that was probably one of the best, just super inclusive, but super condensed, because you could go on and on for days about suicide. So I thank you to the presenters, and I'll certainly reach out and thank them personally. I have never seen the CSSR before, and I think that is a fabulous instrument that I absolutely want to incorporate, and it's substantially better than the one at my site right now. So I'll follow up on that. I've been surprised at the Pride Center, knowing the statistics about the LGBT community, that I haven't seen more suicide. I really thought I might be doing that on a daily basis, but that has not been the case. And I just don't know if we're not reaching those people who are in need of that, or where, because I know it's happening. They just don't know where to come for. So I'm just trying to struggle with that. But thank you very much. That was super good and a great investment of my time.
Good. I'm glad this is useful material. And so if you suspect that there are clients who may be suicidal or have suicidal ideation, and maybe you're not reaching them at your site, I definitely encourage all of you to talk to your supervisors about how can we be more proactive in these situations. Katie, I think you were about to say something also.
Yes. So with us, like doing like the lethality and practicum, I apologize, my dog is something else today. I was like really worried about it, and like I had like a lot of questions, and Jackie's actually my site supervisor, so I asked her so many questions. So I think that kind of helped, like with today, like even like furthering into all those questions I've been asking, just so now that I feel like I have a good handle of it, and I know like the biggest thing that we kind of talked about was just that practicing of saying the words, like asking those questions. But I think I like knowing like the instruments that MHID uses and things like that, like I feel comfortable with it now. But I think it's just because I've been asking so many questions at my site about it, just so that I am aware of what to do.
Yeah, that's great. Yeah, I definitely encourage all of you to keep practicing, you know, kind of like Julia mentioned, if you gotta get yourself a mirror and say it in the mirror, saying it out loud can be really helpful and kind of boost your confidence.
And just to kind of piggyback off of that, find a buddy, right? I mean, y'all are all kind of in that, you know, that same position to where either you haven't had the opportunity to even do a crisis intervention yet, or, you know, you're still very new at it. And so we're all going to be, you know, pretty awkward the first few times that we do it. And so find someone and practice on each other.
All right, so to kind of give you all a little bit of what to expect next, since we still have a good amount of time. So Melanie and I have been collaborating with the drama department to create some role plays of situations that you might encounter when you're dealing with crisis assessment, suicide assessment, things like that. So we're going to watch the role play that they did for us. And as we go through it, I want you all to be thinking about, you know, what are some things that maybe you liked about the role play? What are some things that maybe you would have changed or you would have done differently as the counselor? And we'll just kind of talk about this process of using the CSSRS. Sound good? Okay, so feel free to take notes. And as we go, we're going to kind of stop at different points. And we'll ask you some questions. So as I said, feel free to take notes and just kind of think critically about what's going on in the situation. And so again, these are drama students, so they're not going to be perfect counselors. You know, they haven't been trained the same way that you've been trained. So let's give a little bit of grace there. But here we go. Well, you know what? Let me make sure I'm sharing my volume as well so you can all hear. All right, y'all give me a thumbs up if you can hear.
All right. Hi, Sam. My name is Sydney, and I'll be your counselor today. Before we begin, I want to go over confidentiality with you. Whatever you say stays between us in this room. However, there may be times when I have to reach out to somebody. For example, if you tell me that you want to hurt yourself, somebody else, or talk about abuse against a child, a elderly person, or a person with a disability, I will have to report that as well. Also, if I receive a court subpoena, I do have to release the appropriate information. Do you have any questions about confidentiality?
No.
Then why don't you start by telling me what brings you to counseling?
I don't want to live anymore.
Okay, tell me more.
The other day, I get bullied at school. The other day, some kids beat me up in the bathroom and told me I'd be better off dead.
So what I'm hearing is you felt hopeless, and in your mind, killing yourself would be the only way you can experience relief.
Yeah.
All right, so just kind of your first impression of this clip, you know, what have you noticed about this situation so far?
Well, I like that she just went into the saying, feeling of killing yourself, but I'm kind of stuck. You said not to be critiqued, but kind of, it's such a direct and kind of staccato approach to how she's saying it. She's not really reflecting feeling so much as just shooting words at him. It feels like it's a little bit too matter of fact. I don't feel empathy.
Yeah, it feels very businesslike.
Yeah, for sure. Good. What else? Okay, so as a counselor, what would your next move be? So kind of start thinking ahead of, you know, what plans would you have next?
Maybe do a suicidal assessment.
Okay, yeah. Anybody else?
And so I think we should also preface this. I forgot to mention this, so forgive me. This is meant to be an at-home visit with the adolescent.
Then the environment may not be safe for him, depending on what he may be experiencing at home. When you finish the biopsychosocial, maybe there's some elements of abuse at home that, or just general feelings of unsafe, that a change of environment may get a better response.
Okay. And so with that, are there any like red flags that y'all have seen or heard so far?
I mean, it sounds like he's pretty isolated socially. And I agree with Matt and Narina. It's so hard to get past like the way that she's talking to him. I think in a sense, like the positive of the way that she's interacting with him is it's normalizing. She's not fazed that he's having these feelings or anything. So that's good. But that's, I just had to say that. But something that I'm noticing even in as he was talking is that he doesn't have any support network at school. And I don't know, we don't really know about like his family or anything, but yeah.
Also, he may not feel comfortable talking about it at home.
Mm-hmm. Okay, can you go into a little bit more detail?
He may not feel safe.
Okay. So then what would y'all have done differently? I know I've been hearing a lot of, there doesn't seem to be a whole lot of empathy coming from this counselor, but what else would y'all have done differently if you had been the counselor for this adolescent?
Maybe have the session in the office or the clinic, wherever the assessments takes place besides the home.
Okay, and so what is your reasoning for wanting to do that?
To assure safety.
Who else? Let's hear from someone who hasn't had a chance to talk yet. Yes, Matt, it hurts, but we got to get comfortable with it. I can be patient just like Ashley, so I can wait until someone wants to join.
So one of the like main things that I guess I was just like the thing that keeps on coming to my head right now is that since he's a minor, at some point having to bring up confidentiality and letting him know that they're going to have to bring the parent into the conversation about how he wants to end his life.
For sure. Okay, awesome. Thank you. Anything else anyone wants to add?
I just have a question. So Ashley mentioned that it's a home visit. So when it's a home visit, there is no option to go to the clinic, is there?
What do you mean to go to the clinic? Like to go to like an ER?
No, like because it's a home visit, does it have to be at the home?
No, so it was just so with the drama department, they have different like settings and stuff, and we just like the idea of having a home visit because sometimes that just is the case. But no, it doesn't have to be a home visit. They could have asked the client to come into like their facility or something like that.
Okay, so is the home visit also part of viewing the environment of living, physical, all that stuff?
I mean, it definitely gives the opportunity for that, yes, but it's not like a requirement to do that. Yeah.
I have a quick question. I honestly can't tell because are those like pill bottles in the back?
Yes.
Okay, is one of them opened like with the bunch of pills? Okay, that
Yes.
I wasn't sure. Okay, so that's very concerning.
Yes.
Along with a tall boy of Budweiser back there too.
Okay. Yeah, I was concerned that maybe I wouldn't be able to see that because it kind of blends in with the cactus, and the pillow blocks it a little bit, but good observations.
Yeah. Great.
Just something that, because it's been something that's always expressed at my site, is I also feel like the room should be angled a little differently because she should be closer to the door if, for whatever reason, this child gets like aggressive and she needs to like get safe.
Yeah.
Because I know he's supposed to be a child, but obviously like he looks like he's taller than her.
Yeah, he's a little bit taller than she is. And yeah, I mean, that's a great point. You know, we were kind of just working with the space that we had. You can't see it, but just off to the side, Ashley and I are actually like standing like just out of the frame. So it was kind of, you know, we were definitely limited in that aspect of, you know, where we could and couldn't record, how we could and couldn't set up the room. But yeah, that's a very good thing to take into consideration, right? Because your safety, like, yes, the safety of the client is important, but your safety is also important. And so, you know, if he were to become, you know, violent or something, you know, what would that counselor be able to do? You know, what would her options be? Would she be able to exit the room safely? Especially considering that she is in a home environment, right? She doesn't necessarily know this location very well. And so, you know, it would be a lot more difficult for her if things were to, you know, kind of take that wrong turn. So good.
And for that matter, as part of implementing her own safety and just kind of setting the tone for this environment, the way that the chairs are set up could be pretty confrontational. So keep in mind, this is an older person who is an adult, a counselor working with an adolescent. So this setup may be really uncomfortable for an adolescent. So kind of drawing your chair to the side or kind of at a diagonal could really change the dynamic between the counselor and the client. Okay, so we've got a lot of really good observations. You know, we see there's some alcohol use in the home by someone. We don't really know who at this point. There's some medication out. She's very direct, which in some ways has been helpful, but maybe we would employ a little more empathy, right? So let's see what happens next.
Okay. In order to ensure your safety, I'm going to ask you some questions and you can answer as honestly as you can. I will be asking questions from the Columbia Suicide Severity Rating Scale. The purpose of these questions is to help me determine if you are in danger of hurting yourself or trying to kill yourself. Once we complete this assessment, we can create a plan together to help you stay safe. Is that okay with you?
Yeah.
Okay. Have you actually had any thoughts of killing yourself?
Yeah.
Okay. Have you been thinking about how you might do this?
Yeah. I was thinking about taking my parents' whole bottle of pain medication.
Have you had these thoughts and some intention of acting on them?
Yeah.
Have you started to work out or already worked out details of how you might kill yourself?
Yeah, I was gonna take my parents' whole bottle of pain medication.
Okay. So what do we think about this situation now? We have a little bit more information. What's going through your mind as the counselor?
I feel like the counselor's not taking the time to reflect anything that the child is saying, especially because like it's just like she's going through the questions really fast to get the answers rather than it being conversational. Like we heard in the presentation before, we should keep those conversational in case it is needed.
Mm-hmm. Yeah, she's kind of rushing through it, and sometimes we might do that as kind of initiating it for the first time. Maybe we're uncomfortable with it, so it can be important, as our presenters were saying, to kind of take that breath, assess ourselves, make sure that we're ready to address this too. Good. What else?
Something that's really sticking out to me is that he mentions the pills, and the pills are sitting like in eyes. Like she can see that this is out right now. So like I would want to ask, like, are you the one who took out these medications? Because they're just sitting there. I would want to know, like, if before she walked in, was he about to act on this, on these, and complete suicide? Like, did it get stopped whenever she arrived?
Yeah, great question.
I think I would ask him, have you taken some today? Because it's already open and they're already there. So I would ask, did you already take some already?
Yeah, I was thinking the exact same thing, because that may affect his affect right now, his present state. If maybe he's not intending on no intent at that time he took it to himself, but that may be creating an altered state of mind.
Yeah, so we have a lot of questions about this unsecured bottle of pills. We don't really know what the pills are. They seem to be kind of carelessly laid out. There may not be a lot of safety in the home at this point. So you mentioned something, Matt, about his affect. So what do we think about the client's mental status at this point?
He's very flat. He has a very flat affect here. So when jumping right into this kind of a questionnaire, probably should go through the biopsychosocial background as much as we can to try to find out maybe there's other diagnoses he has. Going a little bit more through that versus going right here. Not to say it's necessarily wrong. I mean, it's great to kind of assess suicidality at that point, but if the next thing that happens from that is you go to the next echelon of care without looking at, okay, what may be some prevalent factors that are relating to this, that if these were addressed, could mitigate the suicidality itself.
Yeah, great. So you're already thinking about what are maybe some precipitating events, what are some protective factors this client may have. You're getting prepared to do that safety planning. I like that. So something that we wanted to kind of point out as well in this section is, the client is very forthcoming with information. The client is very sort of easy at this point, right? He says, he immediately confesses, I was thinking about taking some of the medication here. Something that is important to keep in mind is that some of your clients may not be as forthcoming. And so in this situation, the counselor does not ask, what is your plan after that? Do you have a plan question? So that's something to keep in mind when you're doing your suicidality assessments. Good.
Yeah, she kind of repeated the question because he did offer already the plan, and she went ahead and asked the question. Yeah, so she repeated the question.
Yeah, and that can be another great thing to do when you're doing suicidality assessments, because we do want to be specific with our questions. We want to get as much information as possible and detailed information, right? So that's okay to do as well.
I would just worry though that would almost give the air that you didn't hear me.
Yeah, good point. So she kind of like sped past it, right? Like she kind of almost invalidated that by not saying. So that's part of that conversationality piece where, yes, we have an assessment and yes, we need to ask the specific questions. But if our clients give us more information, we can take those notes and we can say, okay, I know you said earlier XYZ, but let me ask this question to see if there's any more information that I can get from you. Great.
This plan.
Yes.
Have you ever done anything, started to do anything, or prepared to do anything to end your life?
I was going to, I was in the bathroom and and I had the pain medication in my hand, and I sat there for over like an hour just thinking.
Was this within the last 3 months?
It was last night.
Okay. So based off the responses you gave me, it looks like you are highly considered at a high risk of suicide. What that means is that based on your answers, you are at high risk of attempting suicide. In order to ensure your safety, there are some steps we need to take. Do you remember when we first started talking and I told you that there were some limits of what I can do?
Mm-hmm.
Okay, so this falls under that category. We're going to work together to come up with a plan to keep you safe, and then we'll bring in your parent and let them know what's going on.
Okay.
First thing I need you to do is agree that as soon as you leave here, you will go to the emergency room.
Okay.
Okay, so I really want to address that, it's important to recognize that this is a pretty crucial turning point, like in the session, right? So the counselor has determined that he is at a high risk for suicide. And so, there's going to be some additional steps that are going to have to take place. And so at this point, the counselor will definitely be more assertive, and there will be some things that, within reason that she's going to have to pretty much just tell him to do. One of those being, him going to the emergency room since he is that high risk. And so if you were this counselor, how comfortable, or would you be comfortable doing this?
I
Well,
think
the
I
challenge.
would, sorry.
Go ahead.
I think I would call someone to either drive him or maybe drive him myself to make sure, because of he just he just tried last night. It's very recent. I don't know if he has the pills in his pocket and he's gonna take him on the way there.
Yeah, for sure. And, I know every facility is going to be different, but for most places, when you're working with an adolescent, they require the parent to be on site. And of course, this is a home visit. And so the counselor should have made sure, before the session even started, that there was, a parent or a legal guardian there, for stuff like this, in case there is an emergency or something, that the parent could be pulled into session. But yeah, I like that you mentioned that, right? Like, we don't know if he has pills in his pocket. We've already established that there's pills just kind of carelessly laying around. And so we don't know if he's already taken any at this point. So yeah, those are good points. And Matt, I saw that you said that you've been on both sides of the situation. And so you would be more comfortable, or you think that you would be comfortable with that. If you're willing to share, what was it like for you, like on the counseling side of it?
Just knowing that, having the mindset that if somebody's reached that point where they're willing to share with you, where they're willing to even talk about this, and I mentioned it way earlier in during the last presentation, is that there's a spark of hope there, and that guides me through being comfortable. It's like, okay, this person wouldn't even be talking to me right now if they were going to go. And that's the mentality I've been able to keep with it, because it took somebody having that hope in me to keep me here. And so it's kind of a reciprocal feeling I have of this, where I don't take it lightly. I don't think that they're not serious about it, but I definitely see that there's opportunity to make a positive impact on the individual. And so I just let that override any concern I may have that, like we talked about earlier about fear of saying things, fear of manifesting the situation, is that I don't let that BS become part of my thoughts. It's all just focused on you can make a difference right now. Let's focus on them, not on how I feel about it.
Yeah, and thank you for sharing that. And so it sounds like, having kind of that reassurance that, they're at least open to sit here and talk to me about this, really serious thing, that, it should be okay, or at least in your mind, it's going to be okay. And that kind of helps you get through it. And yeah, and so whenever we're sitting in front of a client who is in crisis, especially when they're at a high risk for suicide, that it can be a pretty intimidating thing. Like full disclosure, the first time I had to do this, I was scared the first time I had to do this. And it's an uncomfortable thing. I know a lot of y'all had mentioned that, you wish you had this training before practicum started. Because honestly, like most of the time we don't know what we're doing the first time we do this. And so it's really important to recognize, in this instance, let your supervisor know. Let your supervisor know if you don't feel comfortable doing it. Because most of the time, they would probably be more than happy and willing to sit in there with you and to help you through it, the first time that you do this. And again, that goes really back to making sure you understand the policy at your site, right? Because some sites require you that if you have a client that's in crisis, like you have to go get your supervisor. You don't even really get the option to handle it by yourself, which can be very beneficial for y'all. So making sure that you are taking advantage of getting, of the amount of support that y'all receive as master's students. Because like every year you kind of get less and less support, right? As you move into being provisionally licensed and then fully licensed. And so take advantage of that. With that being said, do you even know your policies at the sites that y'all are at? I see some shaking heads yes, and I see some shaking of the heads no. So those of you who know your policy, are you comfortable? Are you comfortable with that policy in the sense that you know it, and that if you were to have a client like this, that you would be able to successfully follow that policy? Anyone want to care to share? I mean, I appreciate the nonverbals, but
I will. So at MHID, I'm in the intake department. So if a client comes through and they haven't been screened for crisis and they're sitting in front of me and are clearly in crisis, we have messaging on our computer. So I message my supervisor, tell her what's going on. So she is informed what's going on in the room. And then I try to get as many details as I can. So go through our assessment for crisis, our crisis screening, get that information. And that way I can see where they're at. And that way I can give all that information to my supervisor and she'll step in and take the session from there. Just that way I'm not bringing her in and changing that person without having all the information.
Awesome. Thank you, Katie. Okay, what about the people who say no? I'm wondering kind of where do y'all sit with this, with not knowing what your policy is?
Well, I don't know my policies. I'm pretty sure they went over them with me, but I don't remember them at this time. But I do know that I can always reach out to my supervisor.
Yeah, for sure. I mean, that's what your supervisors are there for, right? Is to offer that support. And I'd also encourage you to either sit down and talk with your supervisor and kind of refresh your memory on your policies, or if you were given any kind of handbook or something like that, that's facility specific, review that, because you never know when you're going to end up with a client that has that's in crisis. And so it's gonna be more beneficial for you if you review that. And that kind of goes for everybody too. You may go all semester or all year without having a client that's in crisis. And so it's really easy to forget things, right? When we don't continuously use our skills, it's pretty easy to lose those skills. And so making sure that you are reviewing things. I know that's one of the things that I really appreciate about being at the CTC or the COC, is that I know every semester without fail, we're going to have that crisis and the suicide intervention training. So just making sure, but not all sites are going to have that, right? And so just making sure, like I said, that you're refreshing your memory on how to handle a situation like this. So we know that this is an adolescent, right? And so at what point would you bring the parent in when you're working with an adolescent?
This is Norina. I had a situation where my client, who is 16, was struggling before the holidays, and what I wasn't very supportive parent, but what I wasn't expecting was when we did bring her in, when I felt like I had enough details, I'd already checked with my supervisor. He had instructed me to send them to the ER. And when I brought the parent in and we updated her, she was pretty adamant that she felt her child was making it up and doing it for attention. And, she had just gotten her phone back. So mom was thinking there was a correlation to something happening on the phone. And the phone never came up as part of our conversations. So that was interesting to have that piece of information that didn't apply or had not been discussed with the client. And so then finally, when she did feel like, okay, maybe there is something, maybe you are really suicidal. She said, my insurance plan will make me pay $1,000 copay to go to the ER room. And we don't have the money, so I will not take her.
So what did you do in that situation?
I said, well, let's see what other resources we have available. And I went back to my supervisor, and he was pretty adamant that just send them to the ER, just send them to the ER. And, being a single mom and knowing how $1,000 copay is so hard, I totally get it. So we ended up calling MHID and doing a crisis walk-in over the phone. And so it seemed that when we did a conference call. So when we pulled mom in on that, and client was able to give her symptoms and why and everything, then mom seemed to really settle down, and we were able to get her into MHID the next morning. And we did a safety plan about, making sure all the knives out of the kitchen, kind of watching her, throughout the evening. And then really just asking her to participate in this process by giving it a chance tomorrow morning. So that was really challenging. I just didn't expect mom to create such a challenge to getting help, but it's real. It's very real.
For sure. And that's definitely, crisis or not, it's definitely an issue that, if you work with children that you're going to run into, is sometimes parents can be more challenging, and, recognizing what's behind that behavior, right? So for this mom, it was, probably the financial situation. Having to pay $1,000 copay. I know you said she was a single mom, right? So only one income coming in. And so, you know, the financial aspect of it was probably a big concern, and having to make that tough decision between sending your child to the ER and maybe getting kicked out of your house because you can't pay rent that month, right? And so being able to recognize those underlying the underlying issues when you are faced with either a parent or even a client too, right? It's not just parents. You know, why they're being, you know, pretty challenging. And I saw in the chat, you know, Matt, you said that you were pretty pissed off right now. Do you care to share what was coming up for you?
Just hearing that, my immediate response was, it's not about the money, because you basically saying that in front of your child, because in the way Norenia was saying it, the parent was in front of the child when saying this. So the child, the damage that was done to the child, it reduced them to a dollar amount of, you know, compared their worth to the worth of money. And it just made me angry thinking of the level of damage that was done, and how what possibly could have been a much more salvageable situation with the child is now exacerbated greatly. But it does give you at least insight of the kind of the unsafe nature of the environment that the child is in, right? Because the emotional environment is obviously chaotic and a big factor of why they're in the state they are. So just my visceral response was, what is wrong with this mother?
For sure.
Well, and the other thing was that later, after we debriefed what happened and everything, I saw her like 2 weeks later, because the MHID kind of swooped in and took over for a couple of weeks. And my client said, thank God that you were able to convince my mom that I really am suicidal, because I have told her that over and over again. And basically she has said, you don't know what you're talking about. So my legitimizing her concern and her suicidality was huge. And that was the greatest gift that she thought that I brought to the equation.
And I'm thankful you were able to be the person that was able to help them too.
Yes, me too.
So I want to kind of jump in here and emphasize that this is a great opportunity for us as counselors to really advocate for our clients, especially adolescents, because we have a lot of specialized knowledge about, you know, the implications of suicidality and how it shows up and all of those things that a lot of times parents may not be aware of. And so by holding your ground and being firm about, you know, as a professional, you are coming to me asking for my opinion, you're asking for my help, you're asking for my training and my expertise. This is what I think needs to happen. So I'm really glad that you stood your ground, Narina.
And ultimately met with finding additional resources that did not include the ER. And we did get her to a psychiatrist, and we did get the right medication. And so it ultimately turned out okay. And maybe, you know, the ER is the easy solution in the moment, but maybe slowing that down. So that's what I did, was I just really slowed it all down. I had to cancel my next 2 appointments because I could see that this was just going to take us some time to get through. And that was hard because I had to leave my client, go cancel the appointments, or, you know, it was just like, so you feel like you're spinning a little bit. But ultimately it turned out really well, and she's on the right medication. And yeah, it turned out okay, but it was a little dicey there.
Yeah, and I think that's something, you know, important to recognize, right? Is that, you know, you as a counselor, you're going to have, I hate the word consequences, but, you know, you're going to have other like implications, right? For handling a crisis situation. And so, again, you know, maybe working out with your supervisor, you know, if they know that you're in a crisis session, having, you know, communicating with them and have them either cancel your sessions, reschedule your sessions, and stuff like that. Because yeah, we have multiple clients, we have multiple people that, you know, are under our care. And so making sure that those clients are also getting taken care of, for sure. So one thing that I wanted to kind of touch base with y'all, it's not really a question, but it's just something to consider. You know, for a client, especially an adolescent, being told that, you know, you're recommending that they go to the ER can be pretty scary, right? And that can have either a positive or a negative impact with the counseling relationship. And so something to kind of just be aware of is how are you going to maintain rapport with that client after having this discussion? And, you know, working with adolescents, you know, we have to have some kind of relationship with the parents, right? And so how are you going to maintain rapport with the parents too? Especially like in cases like Norena had, that the parent was maybe a little bit more challenging. You know, how are you going to maintain a healthy therapeutic alliance with them?
Great. So are we ready to continue on to the next one?
Good. Do you have any way of getting there?
My parent brought me here and they're in the waiting rooms.
Perfect. Before we let you go to the ER, we need to complete additional steps. Let's grab your parent and then bring them in here.
Okay.
Okay, I brought you in here because your child is considered a high risk of suicide. In order to keep them safe, we have to do some things prior to that. So first, I need to decide this agreement stating that you will go take them to the emergency room as soon as you leave here today.
Okay.
All right. Next, we will need to come up with a plan, a safety plan. Basically, this is a plan to help you follow when you are having thoughts of killing yourself. By following this plan, you are more likely to stay safe and will not be at high risk of suicide. We will go through this and create this plan for you together.
All right.
What are your warning signs that indicate you might be moving towards a crisis? This could be thoughts, images, moods, situations, or behaviors that you experience typically before you have thoughts of suicide.
It usually happens when I just think about what happened at school. I just keep hearing them say I'd be better off dead.
Any other warning signs you can think of?
No, not really.
What are some things that you can do to take your mind off of the problems that doesn't require contacting another person?
I like watching funny videos on my phone or just laying in my bed.
That's good. Those things seem like they really help you. If those things are not accessible to you, then what 3 people can you contact in order to help?
My parent, for sure. They're my biggest source of support. And then my best friend. They know I've been struggling, stressing out a lot. And then I guess maybe my English teacher. He's really cool and I trust him.
Okay. So go ahead and write down their names here. Let me jump this. Perfect. Now, what professionals or agencies do you know of, or if anything, that can contact you if you are in a crisis?
I'm not sure of any like around here.
Okay, that's no problem. I have a list of resources like the Mobile Crisis Outreach Team and the National Suicide Prevention Hotline that I can write down for you.
Okay.
Last thing, what can you do to make yourself in a safe environment?
I guess we could put the pain medication only where you know, and just so I don't know where it is.
It sounds like that would really help you. Is there anything else you would want to add or change to your safety plan?
I think we're good.
Okay, perfect. If you don't have any other questions, we can go ahead and bring your spouse.
Okay. So what are some things that we notice off the bat so far? The stiffness of the role play aside, what do we notice? Good things,
Well,
bad things?
the mom was agreeable and she didn't really ask any questions. I think they would ask a little bit more than that, but yeah, at least she was agreeable.
Yeah, so that's a good thing. That's
Yeah.
potentially a supportive factor, a protective factor. Maybe as a counselor, we might want to be sure that, yes, some of the responsibility lies with the adolescent to kind of think of some things that would be helpful, but maybe we can draw the parents in too to say, you know, what can you do to provide a supportive home? How can you check in with your child at the beginning of the day or the end of the day, things like that. What else?
I like the fact that she looked for alternative sources for him to not to be thinking about and to protect himself.
Yeah. Yeah.
Kind of like a support system.
Yeah, those coping skills. So we talked about,
Yeah.
you know, kind of looking at funny videos, you know, keeping up with social media that's positive and helpful, checking in with supports, his best friend.
Yeah.
So
and he agreed with the plan,
yeah,
the safety plan.
Right. And that's really helpful. So as a counselor, what follow-up plans would you want to make with this client at this point in time?
Well, to check in later, have mom call when they're at the ER, something like that, or call them later in the evening or in the first thing in the morning.
So confirm that they actually went to the ER, they actually got that outside help. Okay, what else?
I would want to confirm that the mom or other guardian that's in the house has put the medication somewhere safe. That's actually happened.
Yeah, so confirm, you know, if you're doing another home visit, the next time you visit, kind of checking the surroundings, seeing like, okay, what's changed, what hasn't changed. That's a really good one.
Is it one thing I haven't necessarily heard is providing the parents with resources in this when you have, because I mean, yeah, we want to create a safety plan for them, but also while they're in the ER or in inpatient care or whatever, or even not, what kind of supportive resources, literature, or anything specific to the parents of children with SI?
Yeah, I love that. So you're taking a systems approach, you know, what can we do to strengthen the family bonds to kind of address any issues that may be going on there? How can we support the parents? Are there any support groups or maybe even offering the same resources to the parent? You know, the parent may need to talk with someone at the crisis hotline, right? That's great. I love it. So this is probably not the last time that this counselor is going to see this client, right? So we want to schedule follow-up appointments. And something to consider is, when should you follow up with your client? You know, based on their availability, of course, but for some clients who are experiencing severe mental illness, you might want to follow up at a closer time than just once per week, right? A lot of times once per week is a standard sort of time frame. And this can be setting dependent. If you're at an inpatient setting, it might be different than if you are at an outpatient setting or something like that. But certainly we want to schedule those follow-up appointments, and we want to make sure that they attend those follow-up appointments.
There is something I wanted just to add to real quick to follow up on answering Matt's question. So at mental health agencies like MHID at Youth Services, they have a service provider there who's called a family partner. And a family partner is actually an employee who was hired for the role of supporting parents. And they actually were hired because they have experience in parenting their own child that has mental health or behavioral health needs. And they've often been through treatment services where they've had to admit their child and get them services. And they've so the family partner at MHID Youth Services has a caseload, and they follow up with all the parents at MHID. And whenever a case manager or a counselor has concerns about a parent or feels like a parent's very stressed and overwhelmed and needs resources or supports, the family partner will meet with them, and they actually have a curriculum, an evidence-based curriculum for helping parents, and it's called the Parenting Nurturing Curriculum. And so they actually teach them parenting skills in a sense, and it's very supportive. And they'll also host occasionally, they'll host group sessions with the parents. And this has become a very popular thing in a lot of agencies. Like at adult services, they have peer provider support groups, and there's also employees who are peer providers too. Anything that we can do to link parents to resources, it would be very, very helpful, because parents go through a lot. Oftentimes our parents are single parents, they're working multiple jobs, they're overwhelmed with a lot of responsibilities. And also they have their own unmet mental health needs. They've experienced a lot of trauma possibly. So it's really important that we're caring, compassionate, supportive, understanding of our parents as well, and patient with them. Good question.
It's actually great to know that those resources are out there, because as many of y'all in my cohort know, my son has a ASD, and it was a lot of reprogramming on my part to learn how to parent complete in a different way just for that. And as he's gotten to within the last year, his self-harm behavior and suicidal ideation has really started to increase. So I'm constantly in the lookout for additional resources on how we can do things better and be more supportive on our side. So it's good to know that something like that actually exists. And I'd actually like some more information on that.
Yeah, okay. And I think it's also important to notice that, parents, they get scared, right? So, if you're a parent and you're being told that, hey, your child is suicidal, that's a scary feeling too. They feel like they're not in control of the situation. They could feel like, that internal guilt, like where did I go wrong kind of thing. And so providing, resources for those parents, like Dr. I said, to either help with their own, mental health they have going on, or to just cope with what's going on with their child is very important. Yeah, exactly, Matt. That feeling of I failed them, right? They take on that blame.
All right, so Dr. I, if you will just let me or Melanie know what those resources are, we'll make sure to get those passed out, and we will be sharing the presentations from today. So I know someone mentioned that there's on the TexCHIP website, we have all the different CSSRS versions. There's some difficulty with downloading PDF versions from the website for some reason. So I'm going to get some help on that, but we'll definitely distribute all of that information with you. So yeah, so go ahead, take your time, Matt. Definitely, this has been a heavy day. It's been a long day. So again, I just kind of want to check in with you all and see where are we at? How are things? What are some things that you're struggling with? Some things that you want clarification on? Some things that maybe you feel you just want to share?
Do you think Julia would be willing to do just a 1-hour seminar on the CAMs? Remember she talked about the which I have the book, but it's intense, and just having more of an overview would be really helpful. Do you think she would be willing to put something together for us?
We can definitely reach out to Julia and ask her about that. So something that we'll be providing to you all moving forward is a weekly supervision. So this might be something that we can also address in supervision. But we'll definitely reach out to her and ask for more information about that.
Is it okay if I ask a question about the TexCHIP itself? Or
Sure.
Can I get y'all afterwards, whichever is more appropriate for your flow?
Sure. So let me just check in regarding the suicide stuff, any last minute crisis questions you have, and then we'll kind of move to programmatic things. Is there anything else y'all want to address? Okay. So thank y'all all for your participation. Thank you for sticking with us. Again, like I said, I know this is heavy, but I hope this was helpful for you. So now we're going to kind of transition to TexCHIP kind of programmatic stuff. So we wanted to check in with you all. Does everyone have a site? And I know we've spoken to a few of you who are still kind of looking at sites and trying to figure that out, but is there anyone who needs to hash some things out with us?
I'm still waiting for the Senecor. They got all the paperwork, but they just keep updating me that they're still waiting for that. But that's where I'm at.
Okay. Thank you for updating us. Yeah.
I haven't been able to find a site that works with me, but I emailed Dr. I about that too. So just
yes. Yeah, he let us know about your situation as well. So we'll keep in touch with you on that one. Okay, so everyone else has a site. Just give me a little thumbs up. Okay, great. Okay, so what questions do you all have about the TexCHIP program type stuff?
I guess my question was regarding when sites are being solicited for their inclusion into the program, if they are able to communicate like an actual laid in plan of how they do the integrated aspect, because I like the site I'm at Amistad, but they don't have the integration planned out. It's something that my supervisors is going to have the discussions with their medical team or their psychiatric team to find out ways of integrating this, whether it's just quick assessments for depression or any kind of harmful thoughts while they're in the medical situation, or even doing a pre-screening for psychiatry. All of those things, which would be great, but it didn't seem like they really had that figured out or implemented. It's not part of their regular routine that behavioral health does any of those things. So they're trying to figure those things out. And I'm kind of apprehensive on, am I going to get those hours? And I may have to supplement some of my time there with a new site. And so it's got me kind of anxious about meeting the qualifications I need for this program.
Yeah, that's a great question. So when we assess for the sites, we do ask them to talk about how they can kind of get integrated care for you all, what opportunities there are. But Dr. I, it looks like you kind of want to add something.
Yeah, thank you so much for bringing that to our attention, Matt. There are some sites that are probably ahead of others. So for example, like at MHID, we spent a lot of time talking with them and they have an outstanding plan in place. They have a rotation schedule already and they know kind of exactly where to fit students and when they're going to be able to see based off the clinic schedule, when they're going to be able to join in with the doctor, the nurse practitioners. And so some other sites, on the other hand, it's kind of like, well, we have these services here, but maybe they're not, you know, giving you the experience right now that's required of you all. And it's going to really be a responsibility on us to follow up with these sites and make sure that they have a plan for you in place to get those integrated experience hours. And so we'll follow up and we'll make sure that all the site supervisors are aware. Again, we do explain to them the roles and responsibilities that they have and also the expectations that you all have as students. And so hopefully we can make sure that these sites have a plan in place moving forward. We don't want to leave you kind of struggling to know, like having, because that's a very anxiety provoking, you know, thought, like, will I get these hours? You know, like, what am I going to do about this? So, so we want to help alleviate that and make sure that your sites are aware of the responsibilities that they have to get you those experiences.
So following up on that, Dr. I, my site has actually asked me to create the integrative plan. And so I'm down to do that. What a great opportunity. But here I'm going to spend 10, 15, 20 hours creating the program because of the integrative aspects of it. And then I still don't have any direct hours. So all my creation time would go under the hours of preparation for session, I would imagine. And so, you know, is there any leeway on that? Because it may be a good month before I can get all, because they want me to go before the board and ask for permission to do this program. And that's in 2 weeks. So I don't have 2 weeks of direct customer. What do you suggest?
Wow. Yeah, that sounds like a lot of responsibility that's put on you, you know, and what my idea was that these sites would know that they need to make integrated experiences accessible to students. And so if they have medical services being provided, that there's a means for you to just be present and join in and observe and be a part of that experience, as well as refer your clients there, you know. And if it's just a matter of maybe letting them know about a schedule or your availability, then that's one thing. But if they want you to kind of create a whole system for them, I mean, that could be a lot of work on top of the regular responsibilities that you have for direct and indirect hours. So I'll just check in, you know, I'm not going to throw you under the bus or anything. I'm going to just check in on the site and all sites and just see like what plan do we have in place. In fact, as part of the TexCHIP program, we have a lot of assessments going on for how we are planning to improve this experience for students. And we actually have an advisory council that we've put together. And this consists of faculty members, but we also have an advisory council of site supervisors that we're going to invite. And we're going to talk about these issues kind of all together collaboratively. But in the meantime, I'm going to reach out again, check in with the site supervisors and see like, how are the experiences going? And we want to help make sure that, you know, these experiences for students are easy to access, you know, for you all. So we certainly don't want you having to take on more work than you need to. So we'll advocate for you.
Okay, I'll send you the information so you have the right contact people.
Thank you.
Thank you.
Any other questions just about programming? We do have some things that we want to inform you about, some news that we have, but before we share that, do you all have any questions just about the process? Okay. So I'm first gonna, we're gonna talk to you about two things. So we did mention earlier that there is going to be weekly supervision. That is something that Ashley and Melanie are going to be facilitating. And it's going to be in addition to the supervision you already get at your site and in your class. But it's going to be really, it can be in the format that you agree upon with Ashley and Melanie, but I think they may have already a plan on this, so I don't want to speak on their behalf. I'll let them share. But essentially what we're looking to do is provide you an opportunity to talk about your cases, talk about your experience in integrated behavioral health care, even talk about like how you might be implementing some of the materials and knowledge that you're gaining from these trainings, how you're applying that at your site. So it's going to be like a support group in a sense to help you all kind of just navigate this experience with TexCHIP. Ashley and Melanie, do you have any more things that you wanted to mention or work on with scheduling?
Yeah, so our initial plan, right, since there are there's 10 people here, instead of Ashley and I having to do 10 additional hours of supervision every week, our plan was to do a group supervision. Now I get trying to coordinate 12 people's schedules is not realistic. And so right now what we're thinking is to host supervision Mondays from noon to 1 and Wednesdays from 6 to 7 p.m. Do either of those times just not work for anybody? I get, jobs, families, school, your class, all that stuff. But is there a conflict with anybody at this point?
So the times again, Monday noon to 1 and Wednesdays
6 to 7 on Wednesdays. And it'll be held virtually. So you don't have to worry about trying to come to campus or anything like that.
And to clarify, you don't have to come to both. It's just 1 hour, so one or the other.
Yeah, we're just trying to give options.
I can make that.
Okay, so I'm seeing in the chat, a handful of people that's not working for them. And I get every week might be different, right? Because things come up as well. So for those of you who just absolutely cannot make either of those times, just, Ashley and I we'll work with you. If y'all can all find a time that works with all of y'all, that would be great. If not, we can definitely, like I said, find some, we'll get you to your supervision. Because we understand this wasn't something that we had initially communicated to y'all. So it's kind of, it's a surprise, right?
What we can
I
do
know a lot
is,
of y'all already have your schedules pretty set.
I think I got a lag, sorry.
Oh yeah.
What we can do is I'll set up a doodle poll for us and I'll send it out to everyone. So nobody has to commit to anything right this second. Like I said, this is a surprise, or like Melanie said, it's a surprise. So we'll send out a doodle poll and we'll kind of poll for your availability and we'll try to do something that works for everyone. So we'll go from there.
Yeah, like Ashley said, you're not locking it in right this second that yes, you're going to be there Mondays from 12 to 1. We just wanted to put it on y'all's radar because we will have to start doing supervision. So that way you can get those hours as well. And it will count as indirect hours. I know indirect hours tend to really not be the thing that people have issues with because pretty much everything counts as an indirect hour, right? But it will help getting some hours.
Any other thoughts or comments about that before we talk about the next thing? Okay, so yeah, look out for that doodle poll and that'll be very helpful. So we also wrote in our grant that we were going to be offering a course in integrated behavioral health care. And we've created this course now and we're going to be offering it summer 2. And we will require you all to take this course. So you might be thinking, well, wait a minute, what about my schedule? It's kind of like already set up. If it becomes too much of a problem, please let me know and we'll talk about it. But this course will count towards your degree plan. It'll count as an elective for you. And it's going to be offered summer 2. And it's 5345 integrated care strategies in behavioral health settings. I'm going to put this info in the chat, and I'm also going to be putting the course description in the chat. The summer 2 schedule is not up yet, so we don't know really the days and times, but we'll be posting that soon. But this is going to be a class that will have some synchronous components and some asynchronous components. So since it's only like a 5-week course, you know, we're not going to be meeting all the time, but I will have like pre-recorded lectures. I will be having, you know, a lot of resources and materials posted on Blackboard for you all. But we want to make sure that everyone can get in that course for summer 2. But of course, if your schedule is already made up or for whatever reason it's impossible to add it, let me know and we'll talk about it. But it's going to be an important course and a very helpful course, and it will you know, prepare you all in understanding a lot of the different, you know, theories and practices that go on in integrated behavioral health care settings. You'll learn a lot about the roles and responsibilities of different health providers. You'll learn a lot just about you know, new ways of formulating treatment plans and integrated care. So it'll be exciting, and I'll be teaching it. So but yeah, I just wanted to make y'all aware of that one, and so we look forward to having that this summer. Any questions on that?
Quick question. So if we've already met all of our graduating requirements, so then this becomes just an additional credits that we need to take?
It would, if you've already already met all your credit hours, you taking this course would be an additional credit hour that wouldn't be related to your degree. Yeah, but we'll talk about that. In fact, you know, Can
we audit the course?
That's a good question. I'm gonna get back to you on that. Since you wouldn't need it for your degree, right?
Right.
If you don't need this course for your degree, well, I'll check and see with our faculty.
Thanks.
So is it a requirement to complete the TexCHIP program though?
At this point, we are making it a requirement, but if it is something that is impossible for you all to do, then please let me know and we'll work something out.
Okay, so it's kind of one of those things that going forward, it'll be a requirement for anybody who participates in the TexCHIP. Because I'm kind of in the same boat as Norenia. I only need internship.
Okay.
So, but I mean, I'm willing to take the course because I mean, whatever. I've only got literally just internship is all I'm taking, summer and fall. I've managed to arrange things where I have 54 credit hours done by the end of this semester. Okay. So I can take it. I just maybe the concern for others who may not be so fortunate in the way I've structured things.
Yeah, that's helpful info, Matt and Norina. Thank you for sharing that. And so going forward, it will be mandatory for students who are going to participate in TexCHIP, and we're going to make sure that they can fit this course in with their degree plan. But again, if you're in a situation like Matt or Norina where like you don't need this course for your degree because you've already taken all the other courses and electives, let us know. Please let us know. Like you can mention it right now in the chat and we'll write your name down and then we'll come up with a different plan for you all and we'll look at the option of auditing.
I guess I have a question.
Yes.
Kind of specific for my degree plan because I'm just like looking at it because I went ahead and pulled it up so I could see how it would work. If I were to take this course in summer 2, is it possible to take clinical mental health strategies second internship, or is that something I need to do my first internship? Because it's only offered in the fall or summer 2, so.
I
Yeah.
see. Okay. That's a good question. I'll have to get back on that with you too right now to see. So your question then is when could you take clinical mental health counseling strategies, right?
Mm-hmm.
Okay.
I'm kind of in the same boat as Katie as well, because I'm on the addictions track, and my last 2 addictions courses are only offered in summer 1 and summer 2. I didn't
see.
really, yeah, and so I mean, if I have to double up on like summer 2, I will. But I was just curious, like, because I'll be an internship 1, so I want to try to get as many hours I can.
Mm-hmm.
So that was my concern also.
I do know that it'll count as one of your electives for your degree, so you might be able then to just replace it. But I'll have to see, since I'll just have to double check with you all, and then we'll inform your advisors about this, and they'll have more information, because we'll have more of an idea of how it plans out with your respective degree plans, because some of you are in different specializations. So I just wanted to make y'all aware of that, and to look into that this summer. And I think it's only going to be a course we're going to offer in the summer. So even if new individuals want to take TexCHIP, the TexCHIP program, like with the next cycle, they'll probably have to be in this class too. Okay, so thank you all in the chat for sharing this, and we'll definitely take note of kind of who's in this position. So if you can take it, great. If you can't, let us know, and sort of what kind of plays out for you all, and then we'll move forward from there.
Okay, so I actually created a doodle poll for all of us while y'all were working on that. So if everyone could just fill this out, let me copy the link for us. For supervision. And then if you absolutely can't make any of the times that are offered in the link, just send us an email and let us know, and we can set up an individual supervision if we need to do that. So as we said, we're definitely willing to work with you all, because we know that everyone's schedules don't always add up.
All right. Does anybody have any other final comments or questions before we close?
So just something that we haven't talked about yet is just kind of giving them a heads up that we're trying to create either like our own individual TexCHIP shell on Blackboard, or creating like a another like a TexCHIP folder in the CNEP Blackboard shell, so that way we can post like resources and things for y'all as well. So you'll once we get that settled, you'll be able to have access to that. Okay.
So I know some of you are eager beavers, and Melanie and I, we enjoy our weekends. So please give us until at least like Monday to get all the resources and stuff sent out to you, but we will definitely make sure that you get everything that we promised.
Good boundaries.
You will learn them, and I encourage you to learn them. So one last thing, of course, everything has been recorded today. So once the recording is done, we will post it on the website where the current Zoom meeting link to the actual meeting is now. I'll replace that with the recording. So you'll all have access to everything that was said today, so that you can kind of go back and, you know, what was it that she said, and kind of review everything there too.
All right.
Go ahead, Dr. I. You can close us out.
Well, I just wanted to add that we have our next training March 5th, Saturday, March 5th, and we're going to be talking about depressive disorders. I'll actually be facilitating that training. I'll be the one who will be doing the training on an evidence-based curriculum, and that'll be with the Coping with Depression Adolescent Workbook, which is a CBT curriculum, and it's an evidence-based curriculum, and it's used in our mental health agencies throughout Texas and our local mental health authorities, like MHID. And so it's meant for a group and individual facilitation. So it'll be a good one. We'll have also new panelists come, and we'll have similar format where we'll have a case presentation for you. We'll be talking about depressive disorders. We'll have a virtual simulation like we had at the end of this one. So we're excited, and we look forward to having you all, and we'll keep in touch with you all with supervision going forward. But we thank you all for your patience with us and for your participation. And we hope that this is a good experience for you all. But otherwise, enjoy the rest of your weekend.